The world is in the midst of a pandemic, and we are on the front lines. Yet cardiovascular disease is still the #1 killer worldwide and can't be ignored. Welcome to Top 10 Topics in Clinical Cardiology 2020. While COVID-19 has challenged us to take our conference online, course directors Dr. Samin Sharma, Dr. Jagat Narula, and Dr. Annapurna Kinney have created a packed and compelling program. Over the next 2 days, you'll be exposed to new and emerging approaches in the diagnosis, management, and treatment of heart disease, including COVID-19, opinions of clinical and academic experts, and ways to improve overall care and prognosis. Following our 2 days together, attendees will comprehend the COVID-19 disease process and outcomes, learn to assess CAD risk factors and imaging, acknowledge recent transcatheter valve therapies, recognize the issues pertaining to antithrombotics post-DES, incorporate the latest advances within interventional cardiology. Attendees who are present for both days will receive CME credit. In addition, the full program will be accessible online post-conference on our website, www.ccclivecases.org, and YouTube channel CCC Live Cases. Thank you for joining us. There is nothing quite like the study of cardiovascular disease to remind us to strive towards an active, healthy lifestyle. And remember, wear a mask, wash your hands, practice social distancing, stay safe, and enjoy the conference.
Good morning to all participants of this virtual Top 10 Topics in Clinical Cardiology 2020, which is the 11th year. And who imagined that we will be having the meeting in virtual way? But of course, we all know that COVID has changed our life. But the mission, educational mission of the Top 10 Topics of Clinical Cardiology still remains. That is to enrich all our participants with the latest in this field, and of course, quite a bit in field of COVID-19, how it is manifesting from the cardiology point of view. I'm very pleased to welcome all of you, along with my co-chair, directors, Dr. Annapurna Kinney, who, as you can see in the Zoom with doing yoga, really practicing the true healthy lifestyle, and Dr. Jagat Narula. All have been stellar in their field, and the goal is to create the top 10 topics by the world-class faculty and give you the latest, what is going in that field. So I'll ask Dr. Kinney to just make one comment and then go on further. Anu?
Yeah, good morning, everybody. Good morning, Dr. Fuster and all the faculty who have agreed to be part of this top 10. Thank you for this virtual. We never thought our life would be something like this, but believe it or not, I like it. It is not disrupting your life. At the same time, we are getting the education, learning from all the top people from around the world. I'll hand it over to Dr. Narula. Welcome.
Okay, Jagat. So you are the MC for today, and you'll take it. And we, of course, Dr. Fuster already have clearly we all welcome Dr. Fuster for all his guidance and support. And today's all activities, including question answers, we all are there in the conference, but rest of the proceedings will be done by Dr. Jagat Narula, who is the chair of cardiology at Mount Sinai Morningside, and done a tremendous job of both clinical and academic productivity of the institution. So Jagat, thank you very much, and really welcome you, and take it further.
Thank you, Dr. Sharma, Dr. Fuster, Dr. Kinney, and friends. Welcome to the annual Top 10 Topics in Clinical Cardiology. So today we have 5 exciting talks this morning by our expert faculty, followed by a live and interactive question and answer session at 10:40 a.m. And we would love to hear your questions. After the question and answers, there will be another recorded talk that is going to be the non-CME talk, but I can assure you it's going to be one of the most fascinating talks of the subcellular mechanisms of the lipid lowering that you have ever heard. In the chat, please put the name of the faculty member first when you want to ask a question, and then enter your question. The course will be archived in the next 1 week, and it will be available on ccclivecases.org/top10topics, as well as on our CCC Live Cases YouTube channel, which you have been patronizing for such a long time. At the end of the course, please visit the virtual exhibit hall featuring the booths of our conference sponsors. You will be able to view important product information as well as chat to some of the reps in real time via the chat/contact buttons. You will receive an email from CME after the conclusion of the course on Sunday with the instructions on how to take the evaluation and receive your CME certificate. With these introductory instructions, I would like to start and first welcome Dr. Dipti Ichapuria for her talk on American College of Cardiology, the new strategic directions. As you all very well know, that Dr. Dipti Ichapuria is the president-elect of the American College of Cardiology and will take over as the president in May 2021 during the annual scientific sessions of the American College of Cardiology. Dr. Ichapuria is the Eric and Sheila Sampson Endowed Chair of Cardiovascular Health at the Hoag Heart and Vascular Institute, and also the assistant professor at the University of California, Irvine. Dr. Ichapuria is also the chair of the ACC's Task Force on Health Equity. She is an advisor to the ACC's Innovation Program and is one of the editors of the ACC's Extended Learning Program, what you popularly call as ACCEL, as well as also the editor, one of the editors with Cardiology Today. She has held many other leadership positions at the American College of Cardiology, and I've served with her on the board of trustees. She has been the past secretary. She was also the governor for California, also the chair of the board of governors, as well as she was the past president of the California state chapter of American College of Cardiology. So it is my honor to introduce Dr. Ichapuria on her talk, ACC, the Strategic Directions.
Hello, I'm Dipti Ichapuria, and I'm the Vice President for the American College of Cardiology. And it's my pleasure to talk to you today about the American College of Cardiology, the new strategic directions. I have no disclosures for this talk. The ACC of today is really comprised of over 54,000 members representing the entire cardiovascular team, with 79% of the membership based in the United States and 21% internationally, representing 141 countries. We have 48 domestic chapters and 42 international chapters, as well as 21 member sections. And you can see that we span the globe, and we certainly have an international presence and have an international strategy to continue to cultivate this international presence. If you look at the ACC in the year 2000, we were 26,000 members, predominantly made up of FACCs. And now in 2020, what you see is that we have the whole entire cardiovascular team included, including international associates in our cardiovascular team, as well as fellows in training. So very different look to the ACC of today. The leadership and governance include, here's a slate of them, including Athena Pappas as president, Bo Walpole as treasurer, and Dan Philbin as secretary and BOG chair, as well as Dick Kovac, who's the immediate past president. Next year, Ed Fry will become my vice president, and Chris Kramer will be the treasurer, and Joe Marine will be the secretary and the BOG chair, with Athena Pappas being the immediate past president. This is the ACC's 2019 to 2023 high-level strategic plan. As you know, the mission of the college is to transform cardiovascular care and improve heart health. The vision is a world where innovation and knowledge can optimize cardiovascular care. There are 4 overarching goals, And the first is increase relevance as the cardiovascular professional home. The second is to generate and deliver actionable knowledge with the emphasis on actionable knowledge, advance quality, equity, and value of cardiovascular care. And lastly, ensure organizational growth and sustainability. And of course, there are strategies beneath all of this, but these are the overarching goals. Let's talk about the innovation strategy, because this is a very important strategy for the college. And Dr. John Rumsfeld is our Chief Innovation Officer, and he's been leading this for several years now. And now we really have an ACC innovation strategy. And there are three overarching buckets. We're going to lead the digital transformation of healthcare. That's the overarching goal. And we're going to do that via virtual care, remote monitoring, and artificial intelligence-driven care. And we're going to do this by doing surveillance, really looking at the landscape for all three of these buckets and see what's out there. We're going to have a innovation section with the Leadership Council that helps us to set the priorities of the work that's being done. So there's engagement. And then as Dr. Rumsfeld interacts with industry partners, we look at projects for potential partnerships that can help to further the goals for the college in terms of digital transformation of healthcare. In order to successfully do all of the innovation projects, we recognize that it needs to start with a digital transformation. So ACC has undertaken a strategic goal of having digital transformation. There has been a team that's been assembled. There have been consultants to lay out a strategic map for digital transformation and to look at what are the economics of this and sort of figure out how we're going to lay this out for the next several years to come. But the digital transformation, they came up with a sort of a vision statement, which is to create and cultivate a digital first ecosystem to provide trusted, timely, and tailored knowledge and tools accessible across all touch points of cardiovascular care delivery. Another big strategic priority for the college is this movement to clinical guidance and actionable knowledge. Remember, actionable knowledge was front and center in our strategic plan. And there are two components to it. One is to do guideline optimization, which has been done, and I'm going to be telling you more about that, but also to look at all of the guidance documents and tools that we're right now producing, apps, expert consensus, decision pathways, and then say, how can we enhance these and move towards the true clinical guidance that our members would need and want. A really successful clinical guidance has been provided recently through the COVID-19 Hub. The COVID-19 Hub has been very successful with 2.3 million unique views since the Hub was launched. There are many features of this Hub that make it very attractive. There were clinical guidance documents, there was advocacy and policy updates, journal scans and expert commentary, quick links to JACC and CardioSmart education, as well as MedAxiom resources. There were webinars, podcasts, and video archives. And finally, there was clinician well-being tools that were recognized to be very important during this pandemic. There was also an international section on this COVID-19 Hub that allowed our international partners to share their views from around the globe. Let's talk about guideline optimization. The guideline optimization was directly done in response to many criticisms about how long it took to produce these guidelines. And so the guideline optimization process included 31 recommendations to clarify roles and responsibilities, increase efficiency, and integrate continuous improvement. And it is a phased implementation through 2022. And really the expected results are to reduce the production time by 50% from 28 months to 14 months, and really to lay the groundwork for a living guideline. And so it's easier to search and easier to update. So the anticipation is that the first guideline to achieve production schedule of 14 months will be 2022. And so in terms of this actionable knowledge, we know that it all starts with science and quality. The goal is actionable knowledge and clinical guidance. And we believe that digital transformation, innovation, education, and advocacy will all be enablers of this. But really the overarching goal here is that ACC should be the global leader in actionable knowledge and clinical guidance. Our next big strategic goal is diversity and inclusion. You know, diversity and inclusion, as Eugene Yang said, we are witnessing a revolution in medicine through technologies that are globalizing healthcare. If we're going to succeed in cardiology during this transformation, we need to embrace diversity from all angles, including race, gender, religion, and sexual orientation. So really our challenge was to say that we need to work on our diversity and inclusion. We recognize that preventing and treating heart disease requires a workforce that is as diverse as the patients seeking care. And unfortunately, that isn't the case right now. And so therefore, we must create a culture and a profession that's recognized for its diversity and inclusiveness. When you look at the US population and then look at adult cardiology tends to be less diverse in the population. If you look at the Hispanic population in the United States, in this graph, it shows 17%, but we have 5% in cardiology. If you look at women in the United States, over 50% of the population is women, but yet we have 10% representation in cardiology, although this is increasing. We know that there is a business case for diversity with increased profitability, creativity, stronger governance, better problem solving abilities, and more growth opportunities. And so this survey of diversity and inclusion showed that the companies with below diversity scores did not do as well as the companies with above average diversity scores. And so there's clearly a case for diversity and inclusion with increased profitability, creativity, and more growth opportunity. But we also know that more diverse management teams have 19 to 33% higher revenues. And lastly, almost half of all millennials, 75% of the global workforce by 2025 will choose a diverse and inclusive workplace. And so given all of this, we had this alignment of ACC's mission and vision with really the D&I vision. And so that vision is ACC will harness the power of diversity of its members to advance patient care, spur innovation, and improve health equity amongst individual patients and populations. And in doing so, ACC will ensure opportunity for all cardiovascular providers by working towards a fully inclusive organization and profession. And so what we did was to actually put diversity and inclusion in our strategic plan under the increased relevance as cardiovascular professional. And so as we did that, there were clearly three buckets that came out. One was that there needed to be membership diversity, there needed to be leadership diversity, and there needed to be inclusion. As we know, diversity is not the same as inclusion. And at the center, the strategic plan would support that. We would create strategic partnerships, and a D&I task force was born. And so when we talked about the mitigation strategies for D&I, we looked at pipeline programs and said, we need to create more deep and immediate pipelines. We needed to talk about partnerships with partners such as ABC, the Association of Black Cardiologists, the AAMC, and ACGME, as well as the program directors. And then, of course, the birth of the ACC Diversity and Inclusion Task Force, which really came to fruition in early 2017. And then this task force went underway to address the leaky pipeline. And so program 1 addressed the middle school, program 2 addressed young scholars program, program 3 looked at the pre-med pipeline strategies, program 4 looked at the medical student strategies, program 5 looked at the medical resident pipeline, and then the last one, program 6, looked at the cardiology fellows. And really the strategy was to say we've got to create this pipeline of leaders that not only reflect the membership, but our patient population. So we embarked on building the bench of leaders. And so there were leadership programs that were created by creating ACC pipeline programs, such as the Leadership Academy, which is a 2-year program for early career members. And this really teaches them about leadership And really, this has become the pipeline for our future leaders. We're in the 4th cohort of this Leadership Academy. We also have the clinical trials research, which is upping your game. This is a 2-year program with mentorship, development, research proposal, and experience. There's also the overall workforce leadership pipeline, which we're working on by collaborating with cardiovascular societies on developing D&I leaders. So we know that our solution is to create more diversity and inclusion. And one of the ways that we're embarking on this is by launching the Campaign for the Future. And this campaign is to help transform this cardiovascular profession through this more diverse and inclusive, and really by creating more leadership development programs for women and underrepresented minorities, creating these focused fellowships and scholarship programs, by having faculty programs, faculty training programs for diversity and inclusion, and also national and local student outreach programs. All of this is done through funding that we can get from the Campaign for the Future that ACC has embarked on. When we look at the ACC's diversity and inclusion, we had the 1.0, which was really understanding what the principles were, looking at the workforce issues, looking at the business case for it, and then creating the task force and working on mitigation plans. In terms of 2.0, there was definitely a cultural shift that occurred at the college. This was included in the strategic plan, and there were partnerships that were created. There was education with things like implicit bias training that occurred, as well as advocacy that was involved with creating some basic principles with regards to this. But now we're into 3.0, which is a broader definition, and really the focus is on health disparities and health equity. I mentioned to you earlier that inclusion is different than diversity, and I think this slide really says that diversity is being invited to the party and inclusion is being asked to dance. So we wanted to go beyond diversity and really do inclusion. So there were inclusion principles that were done, but really 3.0 is about equity. So we have diversity, we have inclusion, but there needed to be equity. So now it's DE&I, which is diversity, equity, and inclusion. And let's talk about what equality is versus equity. And so equality in this first image is assumed that everyone will benefit from the same support. They're being treated equally. In the second image, individuals are given different supports to make it possible for them to have equal access to the game. They're being treated equitably. But in the third image, all three can see the game without any supports or accommodations because the cause of the inequity was addressed. The systemic barrier has been removed. And that's really what we talk about when we talk about equity. The definition of health equity by the CDC is that health equity is achieved when every person has an opportunity to attain his or her full health potential, and no one is disadvantaged from achieving this potential because of social position or other socially determined circumstances. And as a result of this emphasis on health equity, a health equity task force was launched, and I'm the chair of that task force. And we have really 5 overarching areas that we're going to be focusing on: improving access to care for underserved patients and populations, reducing system and structural barriers which cause health disparity, addressing the socioeconomic determinants of health, leveraging our established tools for broad changes such as education and public policy, and really building partnerships with effective leadership organizations to really promote health equity. And so we created this pictorial for our first task force meeting, which was paving the road to health equity. And we said the 3 pillars of the college are science and quality education and advocacy. And so we created 3 work groups within the task force that are going to look at those 3 areas on the road towards health equity, where everyone has the opportunity to be as healthy as possible, and really creating the infrastructure. So the organizational structure and functions that support health equity. And so a big goal, the task force will be around for 1 year, and hopefully we'll set a strategic plan of work that can be continued for many years to come. Mahatma Gandhi said our ability to reach unity and diversity will be the beauty and the test of our civilization. And so this was a slide that I put up during our first task force meeting because I think that there's a lot of energy around doing this work. And so 2021 really has been full of significant environmental changes with the pandemic. It has created a lot of resources to be stretched and overburdened at times. We've had financial issues both at the system level, individual level. We've had the social distancing requirements, so there has been no in-person meetings and the travel restrictions. All of these obviously have created a lot of stress and maybe some opportunities. But what does all of this mean for the ACC? Well, we've certainly shifted from the live meeting to virtual meetings. We have really embraced the notion of clinical guidance with our COVID hub. We have had an increased focus on clinician well-being. And we've increased our focus on diversity and inclusion by saying that we're going to include equity and really focus on health equity this year. There's been a commitment to innovation and digital transformation that has also occurred. And so I think that what Franz Grodel said is true, that we will meet the future not merely by dreams, but by concerned action and inextinguishable enthusiasm. And so I would say that we continue to have concerned action and a lot of enthusiasm for all of the work that's being done at the college with these very strong strategic priorities. And really, I think at the end of the day, it's about advancing solutions to save hearts and lives now and always. Thank you very much for your attention.
Thank you, Dr. Echepuria, for an outstanding vision statement from the American College of Cardiology. So please send your questions for Dr. Echepuria, but please put her name first, DI, and then go ahead and ask your questions. So now it is my distinct honor to introduce my mentor, Dr. Valentin Fuster, who needs no introduction. I was very fortunate to become his mentee when he joined Harvard Medical School and the Massachusetts General Hospital as the chief of the cardiac unit in 1992 to 1994. Dr. Fuster currently serves as the Mount Sinai Medical Hospital's physician-in-chief and also the director of Mount Sinai Heart. Dr. Fuster also is the general director of the National Center for Cardiovascular Investigation, or better called as CINIC, which is equivalent to the National Heart, Lung, and Blood Institute in the United States. Dr. Fuster was the president of the American Heart Association, was also the president of the World Heart Federation, and is currently the member of the US National Academy of Medicine. Dr. Fuster, who has been named Doctor honoris causa by almost 40 universities across the world. He is author to more than 1,000 scientific articles with an H index of almost 190. He is the most highly cited Spanish research scientist of all times per Google Scholar. He is the editor-in-chief of the Journal of American College of Cardiology, your favorite journal, has also been the editor-in-chief of the Nature Reviews in Cardiology, which also has reached to the impeccable heights now. Dr. Fuster also is the editor-in-chief, as you know, of the most popular textbook of cardiology, the Hearst, the Heart, and is going to be editing its 15th edition, which is underway. So Dr. Fuster has had maximum number of the awards to his honor. He is the legend, living legend of cardiology from the American College of Cardiology, master of the American College of Cardiology. He has had the Grand Prix Scientifique from the Institute of France, considered to be the most prestigious award in cardiology for his translational research into the atherothrombotic diseases. He also has the American Heart Association's Gold Medal Research Achievement Award, American College of Cardiology's Lifetime Achievement Award, and he was declared in 2014 by the King Juan Carlos I of Spain when he designated him as the Marquess for his outstanding and unceasing research efforts and his educational outreach work. So, Dr. Fuster, it is our honor to welcome you for your talk on cardiovascular and cerebrovascular risk prediction from imaging, ultrasound, PET, MRI to genes. Dr. Fuster.
Thank you very much for giving me the opportunity to talk about one of the 10 topics. The one chosen is cardiovascular and cerebrovascular disease, new basis of early prediction and prevention, from imaging to genetics. This is what we are going to talk about. First of all, what about imaging in the early detection of atherosclerotic disease in the different arterial segments? We developed over the years new technology to address 6 segments of the arterial system. We did this in 12,000 individuals, all without cardiovascular disease from the symptomatic point of view, in which we use on the left coronary calcification to address the coronary arteries, and on the right 2D or 3D perivascular ultrasound, addressing both carotid systems, the distal aorta, and the 2 iliofemoral regions. So altogether, 6 arterial regions. And now I'm going to be presenting 5 findings in the last 2 years or so on the PESA study. A study from 4,000 employees, over 4,000 employees from the Bank of Santander in Madrid, between the ages of 40 and 55 years. And here's the first question. By using the technology that I mentioned, what about the burden of atherosclerotic disease in the 6 arterial segments? Here on the left are males, and here you have between age 45 and 49, for example, 1 vessel arterial disease, 2 of the regions being affected, 3, 4, or 5. Altogether, what you see is 2/3 of the individuals at this age already have early atherosclerotic disease by the methodology that I mentioned. And in women at the same age, half of them. So this is a universal disease that actually, or a systemic disease, let's say, that starts at relatively young age. This is the first finding. Finding number 2. Is this disease that we detect early in life progresses? And just a follow-up in 3 years with these technologies that I mentioned, we can say that a number of plaques already progress. In fact, there is progression of disease in 41% of these individuals. This is a progression that goes back to the baseline 3 years earlier. So this is a real issue. And this leads actually to very sophisticated technology. Out of the 4,000 people, in 1,000, we did MRI and PET of the 5 arterial systems that we did ultrasound originally. And these are the findings. Actually, in terms of MRI, we look at fibrotic lesions present in 53% of the overall population of 50 individuals in the carotid system, and significantly higher in the iliofemoral system, fibrotic lesions. And here are inflammatory lesions, and that is with PET, the incidence is lower, but we are now searching the possibility, and we think is a true possibility, that these inflammatory lesions that we call fatty streaks at autopsy, actually they move into fibrotic lesions later on. But this is, we are looking at the natural history of the atherosclerotic disease in terms of quality of what is there over a period of 20 years in these actually 1,000 individuals. And this is the 4th finding. What about age and cardiovascular risk factors? Here you have an increase in age. In the bottom, MRI. As you can see, older we are, higher is the incidence of fibrotic lesions. Within blue is the iliofemoral region, and in the others are the other regions that I mentioned. The same with PET. With age, there is a number of fatty and inflammatory lesions that increase, and again, the iliofemoral region is ahead. And here on the right is cardiovascular risk factors following Framingham. No risk factors, 1, 2, or more than 2. Here we have a similar situation. With MRI, higher is the risk factor profile, higher is the number of fibrotic lesions in the 5 segments I mentioned. And here, actually, we are talking on the top with PET. These are inflammatory lesions. So here, what we are saying is that we have a disease that starts at a young age, is systemic, and progresses according to age and risk factors. And this is going to be published, I think, in the next couple of weeks, and it's fascinating. Machine learning. We all use Framingham. We use the European score study. We use different approaches, but now I'm going to be presenting to you what we learned from these 4,000 people when we use machine learning in terms of predicting the incidence of the plaques or early atherosclerotic plaques that I mentioned in their progression. What we found in these 4,000 individuals, a number of variables that were important. Out of 110 that we look at, these are other variables, very important in the incidence and progression of the disease, as you will see. Some of them will be funny to you, like odd, why leukocyte count? Why hemoglobin A1C? Why vitamin 12? Certainly others you know, LDL, age, cholesterol, and so forth, systolic blood pressure. Well, now we are going to compare the actual risk factor profile as we usually do traditionally, the European score study, the ASCVD approach by the American Heart American College, Framingham at 10 years, Framingham at 30 years. And what we see is no disease, a disease that is one arterial system, 2 arterial system, 3, 4, or 5, doesn't matter. This is the prediction of the different scores of the different lesions. What about machine learning? When instead of these scores, we use the 12 variables I mentioned. Very, very impressive. Actually, these are 2 of the scores that I mentioned in terms of the incidence, predicting the incidence of plaques, so clinical plaques, and this is machine learning. And this is progression, much more accurate and predictive than the conventional scores. What we are really saying, we have to learn a lot about factors that lead to atherosclerotic disease. We are stuck in the conventional risk factors, and there are many others. In machine learning, this is what is giving us the clue that we know very little, and machine learning is going to be quite meaningful to us in the future of addressing cardiovascular disease. And this is just one example. In conclusion, this first part of my presentation about the role of imaging in cardiovascular early prediction and prevention, here we have atherosclerosis is a systemic disease. Second, atherosclerosis begins at a young age, and the educational strategies should not be too late in life, should be much earlier. Actually, we believe should be in children. Third, non-invasive imaging is going to play a very important role for the future. And I'm talking about ultrasound and CT coronary calcification. But certainly ultrasound is giving us a good clue of the early atherosclerotic plaques, fibrotic or inflammatory, in the 2 carotid arteries, in the distal aorta, and in the 2 iliofemoral regions. And here, finally, machine learning has an important role in future prediction of disease. This is all fascinating, is exciting, and that is why it's so exciting, because now we can begin to treat people appropriately, change risk factor profile by getting into this approach at much earlier stages in life. Number 2, imaging in cerebrovascular disease. This is quite exciting. About maybe 10 years ago, we were doing one of the studies in 6,000 people at an average age of 71 years. the bioimage study. And we look the same thing, early lesions with ultrasound in the 5 regions I mentioned, and calcification of the coronary arteries. But in some people, we injected gadolinium to see what happened with magnetic resonance imaging, as we have done recently in the 1,000 younger people that I mentioned. It was fascinating. We began to see like a correlation between the burden of disease in the 6 regions that I mentioned and these lacunal lesions in the white matter of the brain. We didn't have any idea of what it was. But I can say that in the last 10 years, a lot of information has evolved suggesting that the same risk factors that cause large vessel disease, they also can cause microvascular disease in the brain. And as the microvascular disease takes place, these lacunar lesions, ischemic lesions, microinfarcts may occur, and they may affect cognitive function. This is actually the hypothesis that has been evolving over the last 10 years. And here we are actually driving our research into this hypothesis of work. Here we are. Risk factors in address large vessel disease. And risk factors in large vessel disease are associated with microvascular disease in the brain. This is the hypothesis. Microvascular disease in the brain affects the metabolism and the structure of the brain. And once the metabolism and the structure of the brain are affected, cognitive function is affected. And here we have Alzheimer's disease, very fascinating. We all think that the cognitive dysfunction is due to the neurons that are affected inside the cells. We are going to show you in a few minutes that the disease is much more complex than that. Let's see how we are working on this hypothesis of work with these 5 boxes. And this is the study. It's a study between Madrid and New York, where we are addressing in this pathway 1 is about 1,000 individuals, 500 with cognitive dysfunction, and 500 perhaps with large vessel disease. You will see in a moment. In the 500 that we are now beginning to approach neurocognitive function, in some, cognitive function is impaired, in others are not. And we are comparing both groups. And basically, when we see these, we go now into the large vessels, the risk factor profile, calcification, carotid, femoral arteries, ultrasound, and we look at the relationship between the brain and the large vessel disease and risk factors. But what is going on in the brain? We actually look at PET for amyloid, and we look at the microvasculature with MRI, functional MRI. This is pathway 1. And in pathway 2, we start actually looking at the large arteries. Who has calcification of the coronary arteries? And from here we go to neurocognitive function, and then to the risk factor profile, to the ultrasound of the large arteries, and to the brain, either with PET or with functional MRI. So it's like a crossover study, starting from the brain in one group and starting from the large vessels in the other. Number 1, is any relationship between risk factors and large vessel disease? We know there is a relationship, of course, but if you focus here on Framingham, here you have the coronary artery calcification, here you have carotid arteries, and here you have femoral arteries, and in black means more significant, and this is less significant. And I don't have to spend too much time here, but certainly risk factor profile affect calcification, carotid artery disease, and femoral artery disease. We know this, and actually the patients I presented, or actually not patients, individuals without symptomatic cardiovascular disease, the numbers were not large enough. But here we are now. Is risk factor in left vessel and large vessel disease, can this lead to microvascular disease of the brain? And this is fascinating. Let's look at carotid plaque volume versus cerebral blood flow, which is how we measure microvascular disease with magnetic resonance imaging. 96 individuals. And certainly, there was a significant association between the degree of carotid plaques or volume and the cerebrovascular or microvascular flow. And here we use covariates in age and sex, which may affect microvascular disease. They were taken into account. And here we take into account age, sex, and cognitive dysfunction to be sure that independently we measure carotid plaques in terms of volume versus cerebral blood flow. And was a good correlation. More carotid disease, less the cerebrovascular blood flow by MRI. And this is very fascinating. In yellow means significant effect in the perfusion of the brain, and in red is still a problem, but the perfusion is less affected. So it's a very meticulous and very accurate technology to assess the flow in the brain. And this now that we have a relationship between these risk factors, in this case, or large vessel disease, and we use the carotids, I could present the calcification, etc., which shows the same thing. Now that we have this, is any relationship between microvascular disease and the metabolism and the structure of the brain? Very interesting. This is very sophisticated new technology of MR diffusion. So very basically what this technology is looking is actually how the structure and metabolism of the brain is being affected. And for example, in blue is actually is a way to present the results from MR diffusion that means the brain may be affected metabolically and structurally. And what we found in 66 individuals, that higher was the Framingham risk factor profile as a parameter of large vessel disease, for example, that may affect the microvascular disease of the brain, as we mentioned before. There was an association with a decrease in the white matter integrity and metabolism. Very interesting. That is, we are beginning to see a relationship between large vessel disease and risk factors, flow in the microvascular of the brain, and metabolism and structure being affected. And actually, this is a different technology, and we use PET. And here is not Framingham, we use hypertension. And what PET is showing is the decrease of metabolism of the neuronal system in the brain. As higher is the hypertension, more is the decrease in metabolism. And we believe this may be related to the microvascular flow of the brain. This being said, this now leads to the next question. Is this change in structure and metabolism of the brain affects cognitive function? In cognitive function, or MoCA, means more than 26. This is an index, is normal. 18 to 25 is mildly impaired cognitive function, and 10 to 17 is significantly impaired or moderately impaired, and this is severely impaired when the index is less than 10. Making the long story short, in the same 66 individuals, when we had an increase in white matter integrity, it was also an increase in the cognitive function. And that is, we began to look at the relationship between these two parameters. Then, in other words, integrity and metabolism with cognitive function. They relate very nicely. And then I don't have enough information now to show to you, but the fact of the matter is when we have significant risk factors, we find the brain structure and metabolism is affected, as we mentioned, and also cognitive function. This is all very fascinating and are pieces of this puzzle that now leads to the last one that I want to present, and that is what happens with Alzheimer's. Alzheimer's has degeneration of the neurons, very complex, and this is actually in the part of the slide. But then there are two aspects that we are now beginning to find. The microvascular may play a role in Alzheimer's, and also thrombotic phenomena. And let me show you the data. Here is the data with Framingham. And what we have seen is higher is the Framingham score, higher is the increase in amyloid through PET accumulation that is in red as a parameter of beginning to look at cognitive dysfunction in patients with Alzheimer's. And the results are actually significant as the other results that I presented. But here is the study that was just published by my colleague, Dr. Cortez Cantelli Marta, in which in an experimental model of Alzheimer's, in the mouse model, and it's fascinating, as beta amyloid enters into the brain, here in the circulation, it creates a procoagulant state. And in this procoagulant state, the tissue is actually very rich in platelets and fibrin. If these animals progress into Alzheimer's and cognitive dysfunction, which I'm not going to spend time how we measure it, basically they are in a box, we open a door, and these mouse go out very quickly if the cognitive function is normal. If the cognitive function is abnormal, they don't find the door. So interestingly, when we gave dabigatran, and this has been already published, when we gave recently dabigatran in these animals, we can prevent the progression of the disease. And we begin to think that this is because the clotting system in Alzheimer's may be playing a role in the microcirculation by the beta amyloid that is prothrombotic. And here is the dabigatran. This is leading us now to develop antithrombotic trials in patients with Alzheimer's. And we have actually family members of Alzheimer's, 3,000 individuals in the area of Barcelona. And we are now beginning to look at the possibility of testing this particular hypothesis, the antithrombotic approach in amyloid disease. And here is now, I would say to you, is like a summary of what I have been presenting to you, and that is in terms of the brain. And that is, this is a puzzle with data that has evolved in the last 5 years, but we are now trying to put this puzzle together in Madrid and in New York in patients with cognitive dysfunction or Alzheimer's, and in people with large vessel disease in a crossover study. And basically what we are beginning to see that the hypothesis is probably correct, and that is risk factors and large vessel disease are interrelated. I don't think there is a question about it. Risk factors causing coronary artery disease, the conventional risk factors. Here, conventional risk factors and large vessel disease may lead to microvascular disease of the brain, and we prove this with the use of magnetic resonance imaging flow addressing the microcirculation. Then what we have already preliminary data, at least indirect data, that microvascular disease in the brain may affect the metabolism and the structure of the brain, and these may lead to cognitive dysfunction, as I have shown. And finally, what we have is fascinating data in Alzheimer's. Alzheimer's by itself certainly can cause dysfunction, cognitive dysfunction. And for many years, it has been thought that the whole problem is in the neurons of the brain. Alzheimer's was probably correct. Over 100 years ago, Alzheimer's said, my disease, he was a pathology, is a disease of the blood vessels of the brain. Very fascinating. I don't know if he was talking about the phenomena that we mentioned, how risk factors of large vessel disease may affect the microvascular of the brain, which I think is intimal hyperplasia, by the way, it's not atherosclerotic disease, or whether he was talking about the thrombotic phenomena. But certainly now we are beginning to see that Alzheimer's is much more complex. And here's the situation. If we were able to prevent at an earlier stage in life, which has been the first part of my presentation, this problem, probably we would have a huge impact on the brain, not only in decreasing what we call senile cognitive dysfunction, but perhaps having also an impact in the disease, in the Alzheimer's disease. And you say, well, at the beginning, you said we were going to talk about genetics. I can't. I prefer to focus into the imaging information that we have obtained, particularly over the last year or so, and to present these as one of the 10 topics that may have been interesting to you. Maybe next year, my colleagues may choose one of the 10 topics, the genetic aspects of everything I presented, because we are working very much on this. So I just like to finish by saying that this presentation is the result of the work of many people. Each of these individuals has participated in this work that started 10 years ago, but certainly is now crystallizing very significantly, particularly over the last year. And I want to take this opportunity to give thanks to each of them. And to you people who organized this meeting for having chosen this topic as one of the 10 topics of the year. Thank you very much. Thanks to everybody.
Thank you, Dr. Fuster, for a masterly presentation. I'm sure that the audience will have lots of questions, and they would be sending the questions over in the chat box. So please enter Dr. Fuster's name first before you ask the question. And the next talk is by yours truly, myself. And I do not have to introduce myself. Dr. Sharma introduced me. So the topic is on the COVID-19 and myocardial injury. Good morning. So we'll be discussing about the effect of COVID-19 disease on the myocardium. I have no disclosures pertaining to this talk. So this is the very first report of COVID pneumonia from the Wuhan. And as you can see here, that in the subjects who had adverse outcomes in terms of those who were admitted to the ICU versus those who were not admitted to the ICU, those patients were older in age, they had cardiovascular disease, or they had the risk factors for the cardiovascular disease. And indeed, it was confirmed by the Chinese CDC that the patients who were older, they had higher mortality. As you can see, that with the increasing age, there was an increase in the number of the people who died, or the proportion of the people who died. And similarly, the people who had cardiovascular disease or the risk factors for the cardiovascular disease, they also had a higher mortality as compared to the average mortality seen in various centers in China. Now, this is a bit of a complicated slide here, and I would take you through this, and I will try to simplify it as much as possible. You would see here that in the renin-angiotensin system, we have almost always talked about the angiotensin converting enzyme, which is the pressor arm of the renin-angiotensin system. It leads to vasoconstriction, water and sodium conservation, and adverse remodeling of the myocardium as well as that of vessels. On the other hand, about 2 decades ago, there was a counterpart of the angiotensin converting enzyme, which was discovered, that is called the ACE2, which is the receptor also seen on various organs and various tissues of the body. This counterbalances the ACE arm of the renin-angiotensin system and causes the natriuresis, diuresis, and has a favorable remodeling of the myocardium, as well as the antioxidant effects. Now, this converts the angiotensin 2 into angiotensin 1,7, which actually exerts the favorable effects. It has been often thought that the COVID-2, when it enters into various tissues, and we know that it enters into the tissues through the ACE2 receptors, and it destroys those ACE2 receptors. And when we treat these subjects with the ACE inhibitors or angiotensin receptor blockers, it has been tacitly believed that there would be an increase in the ACE2 receptors, and that would be detrimental to these subjects. However, now we know that if the angiotensin receptor blockers are used, the angiotensin 2 remains unused and is converted more towards the angiotensin 1/7. So it is in fact a diversion towards a more favorable side of the renin-angiotensin system. That is why it is suggested that we should not be changing the ACE inhibitors or angiotensin receptor blockers in the patients who develop the COVID disease. Now we know that the ACE2 is present on the various organ and tissues of the body, specifically in the gastrointestinal tracts, various reproductive organs, heart, and the respiratory system. As you can see here, that it is the aerosol or droplet infection. And as it goes through the naropharyngeal mucosa, it is taken up by the ACE2 receptors and is able to enter the cells. It is able to enter the alveolar spaces similarly and is taken over by the ACE2 receptors. And here you can see in one of the very recent reports that there is a diffuse alveolar damage here. As you can see that this is the earlier acute phase where there is a formation of the hyaline membrane. This is the organizing or a phase which may come 4 to 5 days after. So this is an organizing part. And here there is a reparative part. As you can see, the reactive pneumocytes here and the fibrosis which has started to occur. And here you can see some of the inflammation and then the spike protein staining that can be seen in the bronchial epithelium, as well as the spike protein of the COVID virus, which can be seen in the infiltrating macrophages. Now, once it comes here, thereafter, as you can see here, that this is the interaction of the alveolar lining here. As you can see in this area, these are the pneumocytes type 2, pneumocyte type 1, and there is the interaction between the alveolar space epithelium and the endothelium from the capillaries. As you can see here, normally this barrier is the intact barrier, but once the COVID virus is able to enter into the pneumocytes, as you can see here, entering through the ACE2 receptors, it basically eventually would be able to break through the endothelial barrier. Here you can see it in the histology. And on the right-hand side, you can see the comparison that this is the epithelial lining of the alveolar spaces, which has started to disappear because there's a significant damage that is occurring in the alveoli, as this can be seen by the TTF1 staining. And on the other hand, the lining in the capillaries, the endothelial lining, is still pretty much intact and has only been lost at certain places. But as soon as this barrier is lost, there is the entry of these viruses, which comes to the lumen, as well as the macrophages and other cells which have trapped the COVID virus. They would be able to come into the lumen, and these viruses would also be able to hide into the endothelial cells, which is an endothelial monolayer here. Now, in this particular figure, you would be able to see the ultrastructure of various organ systems here, that you can clearly see the viral particles which are present in the tracheal epithelium in the first two subsets here or figures here. And then you will see that they are present in the pneumocytes as well, and then in the enterocytes in the GI system, as well as in the kidney endothelium and kidney proximal convoluted tubule epithelium in this particular case. Now, once it is able to get into the endothelium is normally an excellent barrier against the various adverse effects. As you will see that it is anticoagulant or anti-aggregatory for the platelets. It is pro-fibrinolytic, even if there are some thrombotic depositions which occur, it will be able to take care of that with the help of some of the plasminogen activators, which are endogenous activators. It is anti-inflammatory. It also causes the intact barrier function so that the invading particles or organisms are not able to cross the barrier, then it is vasodilatory also, as well as it has an antioxidant effect. Once there is the entry of the virus into these cells, or there is an inflammatory insult to the endothelial cells, they lose these effects. They become more procoagulant or pro-aggregatory. There is anti-fibrinolytic systems like the release of the PI1, etc. There is also the pro-inflammatory effect. Barrier function is inhibited. There is a vasoconstriction, and there is a pro-oxidant effect in these cases. This report, which has just appeared in circulation, you would see that as the viral particles enter and then the polypeptides are released, these polypeptides also release the granules by exocytosis from the endothelium. And the two most important things which are released are the P-selectin, which is mounted onto the cell surface of the endothelium, and its expression. Also, there is the von Willebrand factor, which is released, which is bound to the P-selectin, and then the platelets are able to come and aggregate on top of it. The P-selectin also acts as an attractant molecule for the leukocytes also, and gradually the inflammation is able to occur, which, as the barrier function is breached, is able to get into the subendothelial regions. So it looks like that it's a micro and a macrovascular disease, which can occur both in the venous as well as on the arterial sides, and the thromboembolic phenomenon would lead to widespread effect. Now, as soon as this all occurs, it looks like that the endothelium is the hub of all the problems here, as has been recently proposed by Dr. Peter Libby and Tom Lucier in their viewpoint in the European Heart Journal, which appeared about a couple of weeks ago. And the most important molecule which is released is the IL-1. These genes are able to induce themselves, so it is kind of auto-stimulatory, and also leads to the upregulation of TNF and the NF-kappa B. And this is essentially the inflammation hub here. It also causes the induction of the interleukin-6, which is one of the very important pro-inflammatory molecule, which through liver releases the fibrinogen, the PI1. So fibrinogen, which is pro-coagulation, PI1, which is anti-fibrinolytic, or which impairs the fibrinolysis here, as well as there is a release of CRP, which we are able to measure as a biomarker of inflammation in the patients with COVID infections. So essentially, this pro-inflammatory, pro-coagulant pathway that we see becomes essentially the key feature in the COVID infection. And it has been demonstrated that if you look at the patients who have a favorable outcome, as shown by the blue line compared to the red lines here in these graphs, that after the 4 days of infection in the subjects who are hospitalized, you will see that these pro-inflammatory, pro-coagulant pathways, they are significantly active in the subjects who have adverse outcomes or who are non-survivors as compared to the survivors, whether it is the D-dimers, interleukin-6, or the troponemia in these cases. Now, in these vessels, it has been shown, at least for the larger vessels, although these data are not available for the coronaries as yet. In this particular case, as you can see in this CT, that the thrombus is occurring in the aorta as well as in the splenic artery here. So if you look at the iliac and the splenic artery in these cases, that there was a significant intraluminal thrombosis here, as well as the inflammation of both within the wall as well as in the adventitial areas, and perivascularly, that there was a significant inflammation. Not only that, there was evidence of fibrinoid degeneration, which was possibly associated with significant neutrophilic infiltration, where it is interacting with the mast cells, and there's a degranulation of the mast cell occurring in this case. There has been an evidence that there is a significant amount of neutrophil extracellular traps which are set up, and that contribute to the damage in these cases. And in the bottom panel, you can see the complements as well as the immunoglobulins that are depositing in there, suggesting that this is a type 3 hypersensitivity the vessel. So whenever you see the complement deposition in the vessels, it probably always represents the hypersensitivity in these cases. Now, this is procoagulant activity which is happening, and you can see the thrombus in the vasculature, as is seen very commonly and very frequently in the autopsies which have been presented so far. It may occur in the deep veins. Maybe a large proportion of the subjects may have the deep venous thrombosis, even up to about 70 to 80% of them. Up to 30% of them have the venous thromboembolic phenomenon, and a smaller number of the cases will have the strokes as well as the limbs and gangrenous toes in these cases. And most importantly, the thromboembolic phenomenon may occur in the upper extremities as well, unlike what we normally see. So when there is the COVID involvement, you can summarize it as was shown in one of these review articles. And these are the hypothetical mechanisms here, that SARS-CoV-2 virus anchors on the transmembrane ACE2 receptors to enter the host cells, including type 2 pneumocytes, macrophages, endothelial cells, pericytes. And it infects the respiratory tract, and particularly the type 2 pneumocyte results in local respiratory damage, followed by progressive systemic inflammation, often leading to cytokine storm with increased levels of IL-6, 7, 22, and CXCL10. Now, as you can see here, that once it is blood-borne and once the various endothelial cells of the body have already been invaded by the virus, it should be easy for the virus to get into the myocytes in the heart, and it should be able to create a significantly large amount of myocarditis. And had it been so, then most of the people you would have seen should have been dying of heart failure and myocarditis. Now, as you can see here, that in the myocardium, there's a large amount of expression of various pro-inflammatory molecules, specifically when the viral load is higher as compared to those where the viral load is less. However, when we look at the histology, we see that there are some inflammatory cells here and there, but in the myocytes, you would not see much of a damage occurring in these cases, regardless whether there was a high viral load or there was a less or a mild viral load. The viral particles are seen in the myocardium. As you can see here, there is an immunohistochemical staining of the viral particles, but viral particles in these cells are essentially in the macrophages or in the interstitial cells. And this was very elegantly shown by a report that comes from Italy, from Dr. Tavazzi's group with Dr. Luisa Arbustini, the pathologist here, who also demonstrated that there was some plump macrophages which were seen in the myocardium within the interstitium here, and this is the electron microscopy of the macrophage, and these carried the viral particles, but viral particles were not seen in the myocardium. And here you can clearly see the presence of the viral particles here. You can see them here with the corona of the S proteins or the spike proteins here. You can see them all either in the macrophages or in the interstitial cells, but they were not seen in the myocytes. Now here, there was a decent report which just came about a week ago, again from Italy, but in collaboration with Mayo Clinic, Mass General Hospital, and University of Amsterdam Medical Center. Again, they saw that there was, at least in approximately 80% or 80+% of the cases, there was macrophage infiltration in the myocardium. Lymphocytic myocarditis was only seen, which was either because of the cytotoxic T cells or because of the helper T cells, but that was only seen in 3 of the cases, or 1/7 of the cases only. And in approximately 1/6 of the cases, you can see that there was or of a fifth of the cases, there was the presence of pericarditis or epicarditis in these cases. And there was also the small vascular involvement. You can see the intraluminal thrombi in these cases, as well as there is a significant amount of inflammation that you can see in these vasculature. At the same time, there was another report which was published in Circulation, where they demonstrated that in 22 autopsy hearts, in 9, there was a significant enlargement of the right ventricular cavity here. And as you can see here, that the right ventricular cavity, its volume is bigger than the left ventricular cavity volume, more than 1.1:1 that was seen. And the inflammation was predominantly in the right ventricular wall, was predominantly the macrophage infiltration. Not only that, in these right ventricles, by the same Italian report which you had seen earlier from Dr. Basso's group, you would see that the complement deposition occur in the myocytes in the right ventricle. And whenever that occurs, unlike in the vessels where it was hypersensitivity, it is believed that this is because of the ischemic damage to the myocytes. And this is something which has a significant clinical implication, which we recently published in our echocardiographic study, which I will come to a little later. Now here you would see that all this is going on. You can see a significant cytokine-based damage which is occurring in these cases, but the viral particles are not seen in the myocytes as much. There have been some reports where there have been isolated myocytes have been shown with the viral particles, but it is predominantly not seen there. So how can that be explained? And here you would see that this is the coronavirus. How does it get into the cell or tissues? It is by the spike proteins of the coronavirus that bind to the ACE2 receptor or ACE2 receptor expression on the cell membranes. But then it requires a co-stimulatory molecule, which is like TMPRSS2, and it cleaves that off, letting the virus be endocytosed into the cell. However, if either the ACE2 is not present or if the TMPRSS2 is not present, so either this receptor molecule or the co-stimulatory molecule, either one of them not being present, the cell will not be able to be engulfed. So in heart, where we see a large amount of the ACE2 expression, we don't see the presence of TMPRSS2 or the co-stimulatory molecule, and hence the viruses are not able to get into the myocytes so easily. And this is the RNA master plots. You can see that in the hearts, there is not much of expression. It is in the lane 3, and the first one is the RNA blot for the TMPRSS2 in the heart as compared to the lung and trachea, which you can see in the row 6, that there is a significant expression of the TMPRSS2. The maximum amount is generally seen in the prostate and in the stomach, etc. So now coming to the clinical implications of all this, the first important thing is the thromboembolic complications. So among hospitalized patients, the new thromboembolism has emerged as an important disease manifestation. The autopsy studies have demonstrated a high incidence of macro and micro thrombi, as I alluded to earlier. The observational analyses have suggested potential benefit for in-hospital use of anticoagulation, yet practice patterns vary significantly due to the lack of rigorous evidence for optimal regimens. In our preliminary analysis of 2,700 patients admitted to Mount Sinai Health System, we found an association between in-hospital therapeutic anticoagulation and improved survival compared to patients on no or prophylactic doses of the anticoagulation. A follow-up study which just got published with 4,500 patients, where 1,000 patients were on therapeutic anticoagulation and 2,000 people were on prophylactic anticoagulation, were compared with 1,500 patients on no anticoagulants. And it was found that the hazard ratio was approximately 50% lower in the subjects who were either on full dose or on the prophylactic dose of anticoagulation as compared to the subjects who were not on any prophylactic or any full anticoagulation dose. And the total mortality in hospital was 25%, with twofold higher likelihood of having the mortality as compared to those who have received any kind of anticoagulation in these cases. So not only that, when you would see the myocardial injury happening, and most likely it is either the microvascular thrombi or it is the cytokine stress in these cases. We reported in 3,000 subjects from the Mount Sinai Health System, where there were large number of African Americans and large proportion of the Hispanic population. About a quarter of these subjects also had the presence of cardiovascular disease or atrial fibrillation, heart failure, or coronary artery disease. 25% had the risk factors for coronary artery disease or cardiovascular disease, and 25% of the patients were receiving the ACEs or ARBs, and a third of the subjects were on statins. We found that in third of the subjects, there was the troponin leak that occurred, suggesting troponemia or evidence of myocyte damage. But as you can see here, that most of these subjects had only a mild troponemia or mild leak, and the less of the people had the severe leak of troponin. And here you can see that those who had coronary artery disease, cardiovascular disease, or risk factors, which are shown here in red color and red dots here, as compared to those who did not have cardiovascular disease or the risk factors, the levels of troponin were always higher in those who had the evidence of cardiovascular disease. And in fact, higher the troponin leak, as you can see here from left to right, the troponin leak is increasing. And if green is the total number of the subjects, and if blue are the patients who have recovered, and red are the patients who have died, you can see that as the level of the troponin leak is increasing, the number of the subjects who are recovering is decreasing, and number of the subjects who are dying have increased significantly. Now, here, this is a subject who is presenting with ST elevation myocardial infarction type of a picture. But as you can see here, there is a right ventricular enlargement in this particular case. In the bottom panel, you will see the patient who came with a normal size of right ventricle. But on the third day, the patient had a significant enlargement of the right ventricle. And as I said earlier, that this is one of the sinister observations, that the right ventricular enlargement and right ventricular dysfunction correlates even regardless of the pulmonary arterial hypertension status, possibly suggesting that this is a cytokine effect on a thinner myocardium of the right ventricle. However, simultaneously, there have some reports which have come from Italy and some of the other parts of the world where they have shown a Kawasaki disease type of a picture. It is not a classic Kawasaki, but something like a Kawasaki pictures, predominantly in the younger subjects, maybe older than what we see Kawasaki in. And these are the subjects, most of them have already not antigen positive anymore, but most of them are antibody positive. And in one of such cases, there was a presence of the viral particles, which was seen in the myocytes also, not only in the interstitial cells as well as in the macrophages, but also in the myocytes. And then you would see that there was some evidence of myocarditis occurring in such cases. And it is possible that this is occurring probably due to the macrophage activation syndrome or because of the very high cytokines in these cases, even after the antigen has disappeared. Now, it has also been shown, and this has created a stir in the athletic industry of at least United States and some of the European countries, that it has been found that the athletes or the people who have suffered from the COVID in past may, even after they have recovered from the COVID disease completely, may demonstrate the evidence of the edema and increase in the extracellular fraction in their myocardium. As you can see here in the mid myocardium, you can clearly see that the T1 and the T2 are increased. And in these subjects where the T1 and T2 are increased, which suggests the presence of edema or the presence of the increase in the extracellular fraction, and also a possibility that you may have the LGE enhancement, suggesting thereby that the earlier fibrosis has started to occur. It has suggested that these people may not be allowed to immediately get into the competitive sports, and the caution has been exercised in such cases. So at the end, I would like to say that if we are able to understand the pathogenesis and the pathophysiology of the disease, we would be able to treat our patients better. In this particular paper or a viewpoint, which is coming out in the American Journal of Medicine soon, we have proposed that the subjects who have the asymptomatic disease, that is, they are positive for their swabs, but they are still asymptomatic, or if these subjects have they are mildly symptomatic and they are not admitted in the hospital, the only drug that would be effective in such cases would be when we have an availability of an antiviral agent. Currently, the only agent that we are able to use is remdesivir, and then once the patient is symptomatic and he gets into the hospital and may not yet be on the ventilatory support, in such cases, probably the antivirals may still work, the steroids and the immunomodulatory agent, quite like the IL-6 inhibitors, may be given in this situation. The plasma therapy could be of help, but as you would have seen that today, there was a report in the morning in Science where it was demonstrated that we have to be careful about the plasma therapy also, because some of the people who have the worst course, these people develop the autoantibodies to type 1 interferons. That is most likely interferon alpha and interferon omega. In these cases, the plasma therapy we should be careful about the plasma therapy, that it may not give the autoantibodies and it may not suppress the interferon effects or the favorable effects in the patients. However, once the patient is on the ventilatory support for a long period of time, probably all these agents that we have talked of may not really be helpful. And here it should only be the supportive therapy which would be able to help these subjects. Ironically, most of the studies that have been done, be it randomized or observational studies, they have all been done in this phase where you would not expect much of an impact of the drugs which may be more effective in the early phases of the disease. Thank you very much. So thank you for listening, and please send your questions in the chat box. Please put my name before you send the question. And now it is my honor to bring my wonderful friend, Dr. Stefan Achenbach. Dr. Stefan Achenbach is the president of the European Society of Cardiology for this year and the next year, and has had the distinct role to change the European Society of Cardiology conference from the physical conference to the virtual conference this year, and it did remarkably well, as we all would agree. The chairman of the Department of Cardiology and professor at the University of Erlangen, he is by training an interventional cardiologist, but is better known as the father of cardiovascular CT. He was the inaugural president of the Society of Cardiovascular CT, as also the inaugural editor-in-chief of the Journal of the Cardiovascular CT. So Dr. Stefan Achenbach, who has to his credit the first EBCT paper when he was at Mass General, it was a fabulous New England Journal of Medicine paper, and thereafter the first demonstration of the CT angiography, and bringing it to the latest contribution of his, where he has demonstrated the role of CT imaging in possibility of even identifying the coronary inflammation by looking at the fat attenuation index pericoronary vasculature. So my distinct honor to bring Dr. Stefan Achenbach for his talk on non-invasive imaging of stable coronary artery disease post European Society of Cardiology guidelines. So Dr. Achenbach.
Dear ladies and gentlemen, it's my pleasure to speak to you about non-invasive imaging of stable coronary artery disease after the ESC guidelines. What is meant by this are the ESC guidelines on chronic coronary syndromes, which were published approximately a year ago in the year 2019. My name is Stefan Achenbach from the University of Erlangen in Germany, and CT imaging, as you will see a little bit later, is one of my focus areas. So I'll put in a little note about cardiac CT here and there, because cardiac CT has become a new focus a little bit of these non-invasive imaging aspects of imaging in chronic coronary syndromes. But before I start going to the details, I would like to start with three relatively basic considerations that it's good to make ourselves aware of. Number one, what is it that we want to know in patients who have suspected coronary artery disease? Well, on one hand, we want to know whether the symptoms the patients are complaining of are caused by ischemia. And if we think about coronary angiography in revascularization, we specifically want to know whether these symptoms might be relieved by revascularization. The second question, of course, when patients are complaining of chest pain, we want to know whether these patients are at increased risk for myocardial infarction and/or death, and whether revascularization or medication with statins and aspirin might reduce that risks. So these are the two different questions we want answered. A, are the patient's symptoms caused by ischemia, and can they be relieved by medication and mainly also revascularization? And B, is the patient at increased risk for myocardial infarction and death? In order to get oriented about whether symptoms might be attributable to coronary artery disease, amenable to revascularization, typically what we're looking for are stenosis, narrowings of the coronary arteries, even though we know that looking and finding for stenosis is not necessarily enough, because quite a few stenosis look relatively high grade but do not cause necessarily ischemia. So typically a correlation of stenosis on one hand and ischemia on the other is needed before we know that a given atherosclerotic lesion in the coronary arteries causes stenosis, will benefit from revascularization. As far as the risk for events is concerned, even looking for stenosis is not enough, because as you all know, and probably who have completely normal or almost normal coronary arteries on one day, and then as this patient 4 days later experience myocardial infarction, acute coronary syndrome caused by plaque rupture. The plaques that rupture are not necessarily high-grade stenosis. They can be relatively minor. And then suddenly the acute coronary symptoms occurs without underlying high-grade stenosis, and often in many patients without any preceding symptoms. Based on the data from the mid and early 90s, we know that about 70% of myocardial infarctions are caused by lesions which angiographically, in the weeks before the infarct, do not have an appearance of a high-grade stenosis, but appear to be less than a 50% stenosis. Because acute coronary syndromes are caused by the rupture of atherosclerotic plaque, it might in fact be useful to visualize these plaques. And this is where CT comes in for the first time, because CT angiography allows, if image quality is sufficient, to visualize both calcified plaques. Here's one and here's one calcified plaque, and also non-calcified plaques. And if image quality is really good, we can quantify and to some extent also characterize coronary atherosclerotic lesions. And since plaques are caused by, since acute coronary syndromes are caused by plaque rupture, intuitively, this might be useful to see, detect, or rule out coronary atherosclerotic plaque by cardiac CT. In fact, there is some data that indirectly indicates that using CT to work up patients with suspected coronary artery disease might be beneficial. Most frequently cited is the Scott Hart trial, 4,200 patients with suspected coronary artery disease in Scotland. They were randomized to receive as the first diagnostic test either coronary CT angiography or standard of care. The standard of care in most cases was exercise EKG testing, not the standards that you have in the US mainly, where ischemia imaging, SPECT, for example, is often used as the first test. Anyways, these patients were worked up either by CT or by exercise testing. And it turns out that after 5 years, the rate of non-fatal myocardial infarction in the standard of care arm, 3.9%, was significantly higher than in the CT angiography arm, 2.3%. Low event rates overall, as usual in these studies, but the question is why? The test itself doesn't change anything. So what was the consequence of this initial test that might have contributed to the difference in myocardial infarction incidence? And we can see, based on the analysis of this trial, that in patients who underwent CT, preventive medication, aspirin and statins, was started more frequently, 14% of patients, than in patients who underwent the standard of care, mostly exercise testing, only 4% of patients. And it was also stopped more frequently, probably because CT demonstrated the absence of plaque. This is a little bit speculation, because treatment was left to individual decision. In this trial, where only the first diagnostic test was randomized, but the trial suggests that possibly the ability of CT to visualize plaque and to initiate or terminate risk-modifying therapy based on the study result might have contributed to the decreased risk of myocardial infarction in the group of patients who were randomized to coronary CT angiography. A second basic consideration is, as we think about testing, non-invasive testing for coronary artery disease, how accurate are our tests? How accurate are our tests, the non-invasive tests, to find patients who have coronary artery disease? And of course, we repeatedly see studies that look at the accuracy of these tests. It's a little difficult because comparing an ischemia test to invasive angiography, you compare the detection of ischemia to the presence of stenosis. So these test results also always have to be taken with a grain of salt. But here is one very recent example, which compared in a large cohort of almost 800 patients, magnetic resonance stress imaging combined with late enhancement, function and rest imaging, so a complete magnetic resonance protocol. Compared this to invasive angiography, and mainly based on the identification of stress perfusion defects, found a sensitivity of 79% and a specificity of 87% to identify stenosis of 70% or more in the invasive angiogram. Sensitivity approximately 80, specificity 87% for stress myocardial and magnetic resonance imaging. And similar comparisons, of course, are available for all kinds of tests. The guidelines that I mentioned at the beginning undertook a review of the available evidence as far as accuracy is concerned for the non-invasive tests. And you can see exercise EKG has a poor sensitivity and a good specificity. Counterintuitively, often we assume the opposite. But in unbiased trials, sensitivity is low and specificity is pretty good. PET, of course, has excellent sensitivity and specificity, and excellent means about 85%. SPECT also in the 70 to 85% region. Stress echo around 85%. Stress MR, as we just saw, about 90% sensitivity, 80% specificity. If you take the pooled available data, the recent trial had better specificity but lower sensitivity. Coronary CTA, 96% sensitivity, 82% specificity. In general, you can say that if these studies performed by experts, the sensitivity and specificity, of course, will range from patient to patient, but will be approximately in the 85% range. That's probably a reasonable assumption, potentially with the exception that the sensitivity of coronary CTA is close to 100%. But 85% seems to be a reasonable value. This is how accurate our tests are to find patients with coronary artery disease based on non-invasive testing. And a third question, a third basic consideration, which at first seems almost ridiculous to ask, is testing always useful? Is testing always contributing towards knowing more about the patient? Or other way of phrasing this is, after the test, do we know more about the patient's condition than before the test? Typically, we would assume yes, but is this really the case? When we see a patient who has complaints, for example, a patient who complains of chest pain, and we think, does this patient have coronary artery disease? We typically estimate a pre-test likelihood. Before performing any other tests, we try to assign a likelihood to this patient. Definitely, this is something, probably, I don't think so. So we give the patient something on a spectrum continuity of likelihood that the patient may or may not have disease. And typically then the next idea is to perform a test in any disease. It can be a blood test, it can be an imaging test, or whatever other test. And the idea is that in general, if I perform a test, I will know more about the patient after the test than I did before the test. The test will give me a clearer picture. The test will give me a better estimation of the likelihood that this patient has disease. So conventional thinking that we all typically do is that after a test, the likelihood of disease assigned to a given patient is closer to reality than before the test. So we conclude that typically testing will be helpful, but is this really the case? We have to consider that no test is 100% accurate. And we still typically assume that even if a test is not 100% accurate, there's probably still some value to the test. But let's look at a hypothetical group of patients who have coronary artery disease. And we know that our tests for obstructive coronary artery disease, our non-invasive tests, have a sensitivity and specificity of approximately 85%, which means that 85% of test results will be correct and about 15% of test results will be incorrect. So now let's look at a large group now of 1,100 patients, 100 of which have disease. We have 100 patients with disease. We have a sensitivity of 85%. So 85 of these 100 patients will be detected and 15% will be incorrectly classified as not having disease. 85 correct, 15 incorrect. We have 1,000 patients without disease. So with a specificity of 85%, we will identify 850 correctly as healthy and 150 will incorrectly be classified as having disease, even though they do not. Specificity 85%. If we sum this up, we will have a total of 935 patients with a correct diagnosis and 165 patients with an incorrect classification. However, had we simply assumed that all patients are healthy, we would have 1,000 patients classified correctly and only 100 patients classified incorrectly. So we can see that performing a test classifies fewer patients correctly than we would have classified correctly had no test been performed. Sometimes, as a result of performing a test, the assessment of the patient after the test is worse than it was before. This is true in particular for very high and very low pretest likelihoods. Or as a consequence, the value of diagnostic testing depends on the pretest likelihood. Sometimes it may actually be better to not use any test. And it also depends on how the test performs in patient cohorts with low, intermediate, and high prevalence of disease. So the three very basic considerations: what do we want to know in patients with suspected coronary artery disease? We want to know about whether the symptoms are caused by coronary disease and how the prognosis of the patient is. How accurate are our tests to find patients with coronary artery disease? In general, approximately 85%. And is testing always useful? Not necessarily. In very low and very high pretest likelihood situations, performing a test might potentially give us a worse estimation of the patient's true likelihood of having disease than if no test had been performed. So now back to the guidelines. The 2019 ESC guidelines for the diagnosis and management of chronic coronary syndromes, they start with pretest likelihood, and they show us that even patients presenting with relatively typical symptoms, even in patients at somewhat higher age, the pretest likelihood for having coronary artery disease is not extremely high. Typical atypical non-angular chest pain, 70-year-old male, non-angular chest pain, pretest likelihood 22%. They also list dyspnea as a possible symptoms, and the likelihood assigned with dyspnea is approximately the same as that with atypical symptoms. Notably, the guidelines point out that the availability of information about multiple risk factors in a patient, the presence of an abnormal EKG, and importantly also wall motion abnormalities in echocardiography, here you can see an anterior wall motion problem, will significantly change the pretest likelihood assigned to the patient. The likelihood of coronary disease is modified substantially if there's an abnormal EKG, if there's a wall motion abnormality in echocardiography. And this is why the guidelines say that in every patient with suspected coronary artery disease, with suspected chronic coronary artery disease, a resting TTE should be performed. This is a class 1 recommendation, should be done to look at alternative diagnosis, aortic stenosis and other diseases, to look at identification of regional wall motion abnormalities that increase the likelihood for coronary artery disease, and to also measure left ventricular ejection fraction. So the guidelines point out that you assess the pretest likelihood based on gender, age, and the nature of symptoms, but a normal exercise EKG will decrease the likelihood. An abnormal exercise EKG will increase the likelihood. Left ventricular dysfunction will increase the likelihood. Risk factors for cardiovascular disease will increase the likelihood. For all of this, there are no numbers, but it needs to be sort of integrated in the physician's estimate of how high the patient's pretest likelihood for having coronary artery disease actually is. And then a spectrum of tests is available that can be chosen. Imaging stress tests such as SPECT, stress echo, or stress CMR, CT angiography, and we know that all of these tests have accuracies in the about 80 to 85% range. Stress EKG is not recommended because the sensitivity is relatively low. The guidelines emphasize that revascularization should usually not be done based on a single test alone. Even if you perform invasive angiography, FFR should be done to assess the presence of a high-grade stenosis if no ischemia test is available, unless the stenosis is more than 90%. If you do CT angiography as a test, then stress testing needs to be done to demonstrate whether the lesion seen here actually causes ischemia. Alternative, you can go to invasive angiography and perform FFR or IFR. And finally, even if you perform non-invasive testing for ischemia, then the next test will have to be coronary angiography, potentially also with FFR and IFR added if there are multiple stenosis seen and it's not completely clear which stenosis of these causes ischemia and which does not. The guidelines suggest a system that actually makes it clear that often more than one test will be needed to get complete information. And the patient can enter this system of several tests at various points. Patients can go to coronary CTA, patients can go to non-invasive testing for ischemia, and some patients even to invasive coronary angiography as the first test. Invasive coronary angiography only in few patients, preferentially considered in those who have very high clinical likelihood and typical symptoms refractory to medical therapy. There it might make sense, especially if there's also left ventricular dysfunction suggestive of coronary artery disease, to move immediately to invasive angiography. This is what the guidelines say. Coronary CTA preferentially considered if there's a relatively low clinical likelihood that the patient has disease, but also if the patient has characteristics that promise high image quality, local expertise is available, and a high NCT scanner can be used. And finally, non-invasive testing for ischemia, preferentially considered in those who have a relatively high clinical likelihood of finding disease, and particularly when there's a wall motion problem in echocardiography, so that the physician also wants to know about viability, because the non-invasive testing for ischemia typically also includes viability imaging, which is important information when proceeding to invasive angiography. If an stenosis of more than 90% is found in invasive angiography, or if a stenosis is found that has an established correlation to ischemia, either based on non-invasive testing or based on invasive FFR, then revascularization would be indicated. This is another way in which the guidelines display this choice of testing that is available to the physician. No testing in very low pretest likelihood situations, potentially immediately invasive angiography with the availability of FFR or IFR in the very high pretest likelihood, and in between you can choose either coronary CTA or testing for ischemia, SPECT, stress MR, stress echocardiography, and the choice of test is based on the clinical likelihood that the patient has disease, on patient characteristics and also patient preference, on the availability of a test, and also importantly on local expertise. It is new in these guidelines that coronary CTA is labeled as the preferred test in patients who have a low range of clinical likelihood, no previous diagnosis of coronary artery disease because it's difficult to image patients who already have stents, for example, and who have characteristics associated with a high likelihood of good image quality, typically meaning relatively low heart rate, definitely irregular heart rate, and the absence of severe obesity. It is in fact interesting because this is something new for guidelines. Guidelines will typically always, say thing is good or a thing is bad. But here, these guidelines on chronic coronary syndromes, I think very reasonably say that the test should really only be selected if a patient characteristics allows to expect high image quality for this given test. And also, importantly, if there is local expertise. In coronary CTA, in order to achieve good image quality, the prerequisites are regular and low heart rate. Often the heart rate is even lowered further for the test itself by giving beta blockers, and the absence of substantial obesity. Just a word on follow-up testing. In patients with established coronary artery disease, the guidelines recommend periodic echocardiography after a revascularization is performed after 1 to 3 months, and then possibly 1 year later and every 3 or 5 years after that. Stress testing for inducible ischemia can be performed when patients report changes in symptoms, and also potentially to do it periodically every 3 to 5 years to reassess the presence of ischemia. So in summary, with current technology and knowledge about test performance, there's a high degree of freedom in choosing the initial tests in patients who have suspected coronary artery disease. You should make it dependent on pre-test likelihood and also on patient characteristics, local expertise, availability, and patient preference. From what I said in the beginning, the ability of CT to not only rule in or rule out stenosis, but to also visualize plaque might allow improved identification of at-risk individuals, but there's no really hard data available on this as of yet, what the detection of plaque in CT means, for example, for the initiation of statin therapy. Importantly, one single test might not be enough. It might be necessary to image both morphology and ischemia. A sequence of tests might be appropriate. And invasive angiography should be regarded as a test and not as an automatic route to PCI. Unless stenosis of more than 90% are present, the demonstration of ischemia associated with this stenosis, either by FFR or by non-invasive testing, is required before proceeding to revascularization. With this, I would like to thank you very much for your attention, and thank you once again for being part of this presentation.
Thank you, Stefan, for an outstanding discussion on the non-invasive testing for the chronic stable coronary syndromes. And now it is my honor to introduce Dr. Silvio Inzucchi, the talk on heart-friendly glucose-lowering regimens in type 2 diabetes. Dr. Inzucchi is professor of medicine at Yale School of Medicine in New Haven, and also is the chief of the section of endocrinology. He's director of the Yale Diabetes Center and is a very well-known author on various scientific and layman articles on the diabetes management. He serves as the co-chair of the American Diabetes Association and the European Diabetes Association position statement on the management of hyperglycemia and type 2 diabetes, and has held leadership roles in several large clinical trials, the most important ones being the SGLT2 inhibitor studies. So Dr. Inzucchi, we are honored to have you here. Thank you.
Hi, I'm Silvio Inzucchi, and it's a pleasure to be here at the top 10 topics in clinical cardiology at the Mount Sinai School of Medicine. My topic is heart-friendly glucose-lowering regimens in type 2 diabetes, and I think most of you know that there's been a lot of change in the pharmacopoeia to manage patients with type 2 diabetes, and there should be a significant interest from the cardiology community because at least 2 of these drug classes that are relatively new have been demonstrated to have significant cardiovascular benefits. So these are my disclosures. And the way I've structured the talk is to first review the notion of glucose lowering and its impact on cardiovascular risk, to then review the landscape of type 2 diabetes medications. This will put what comes next into context. And then we'll review two drug classes which are relatively new, the SGLT2 inhibitors and the GLP-1 receptor agonists, and their impact on cardiovascular outcomes from large cardiovascular outcome trials. And then we'll review updated treatment guidelines. First, let's review glucose lowering and CV risk reduction itself. One of the important points that we've realized over the past several decades of type 2 as well as type 1 diabetes trials is that glucose control has a significant impact on reducing microvascular complications, primarily retinopathy, but to some degree albuminuria and neuropathy as well. In contrast, however, control of blood glucose has had minimal impact on cardiovascular outcomes and including mortality. So this has been a bit of a conundrum in clinical trials. Why, when you improve the major metabolic abnormality in type 2 diabetes, aren't you able to impact the major mortality reason in patients with diabetes, i.e. cardiovascular complications? In fact, in one study, ACCORD, despite a nearly 1% difference in hemoglobin A1C between the conventional treatment and the intensive treatment group, there was actually no impact on overall cardiovascular complications, and if anything, an increase in mortality, mainly cardiovascular mortality. And this led to a lot of introspection in the diabetes community as to whether we had this right, whether controlling blood glucose to this intensive a degree would be beneficial for the cardiovascular system. Well, let's look at the landscape of type 2 diabetes medications, because glucose lowering itself doesn't have any major impact on cardiovascular complications. So perhaps individual medications with maybe off-target effects could advantage the cardiovascular system. Before we do so, let's review the pathophysiology of type 2 diabetes, because if you understand this, you can more easily understand the mechanisms of actions of the major glucose-lowering medications. Type 2 diabetes actually does not start in the pancreas, as does type 1 diabetes. It starts in peripheral tissues, namely muscle and fat, where insulin resistance is demonstrated. In the context of insulin resistance, the pancreas needs to make more insulin to conduct glucose metabolism, and therefore patients who are obese, pre-diabetic, on their way to developing type 2 diabetes may actually have hyperinsulinemia, high insulin levels, in order to keep glucose levels in the normal or near normal range. Over time, however, in a subset of these individuals, there is pancreatic exhaustion, as we say, and a gradual decrease in insulin secretory capacity. And now there's a disconnect, not enough insulin coming from the pancreas and too much insulin being demanded by these peripheral tissues. And that is obviously a recipe for hyperglycemia. The liver is also involved. It is a glucose producing organ. Hepatic glucose production maintains plasma glucose levels in between meals and overnight. That is enhanced in patients with type 2 diabetes. They are not able actually to shut off their glucose production even after meal ingestion. One can consider that the liver is also insulin resistant. The GI tract is also involved in diabetes. It is obviously the conduit through which carbohydrate calories eventually appear in the plasma. But also there is an incretin system, a neuroendocrine dialogue between the GI tract and the endocrine pancreas. These incretin hormones are released after meal ingestion, augmenting insulin secretion and suppressing glucagon secretion, which also serves to reduce hepatic glucose production. Those signals are not working well in patients with type 2 diabetes. And finally, the kidney is also involved. It is a safety valve, if you will. It releases glucose at a plasma glucose concentration of 180 milligrams per deciliter, which translates directly to a similar concentration of glucose in the glomerular filtrate. The glucose threshold for excretion is actually increased in patients with type 2 diabetes to 230 to 240 milligrams per deciliter. So that safety valve is not working as well in patients with type 2 diabetes. It's a bit of a metabolic mess. Multiple abnormalities and multiple organ systems. And as we'll see later on, this is one reason why there are so many drugs to treat patients with type 2 diabetes. In fact, there are 12, but I'm here showing only 7 because these are the 7 major drug classes used in the United States. The drugs can be distinguished into 3 groups. There are those that augment insulin supply, obviously exogenous insulin and the sulfonylureas. 2 drugs that increase insulin sensitivity, so can be considered insulin sensitizers, the thiazolidinediones or glitazones, which mainly work in skeletal muscle, and metformin, which works mainly in the liver. 2 drugs that enhance the incretin system, the DPP-4 inhibitors and the GLP-1 receptor agonists, and the one that stands alone mechanistically are the SGLT2 inhibitors, which are glucoceuric agents. In 2015, we put together the ADA-EASD position statement for management of hyperglycemia in patients with type 2 diabetes. The committee felt that lifestyle change was important, particularly in the obese individuals, followed soon thereafter by metformin as initial monotherapy. If glucose control was not achieved, then one of 6 other medications could be used: a sulfonylurea, a TZD, DPP-4 inhibitor, SGLT2 inhibitor, GLP-1 agonist, or basal insulin. If dual therapy was not effective, then after several months, triple therapy would be recommended. For instance, a patient would wind up on metformin first, then perhaps a DPP-4 inhibitor, and then one of these 4 drugs could be added to the regimen. Over time, a small segment of this population may require combination injectable therapy, such as basal insulin with mealtime insulin, similar to what we'd use in type 1 diabetes, or basal insulin plus a GLP-1 receptor agonist. Here now is, in chart format, the individual classes, the 7 most popular classes or categories of glucose-lowering medications, some of the generic names of these classes, the mean hemoglobin A1C reduction, the mechanisms involved, and we've touched upon these already, and also the pluses and minuses to using these medications. For instance, metformin, some weight loss, no hypoglycemia, and a potential reduction in cardiovascular events. Those are the positives. On the negative side, gastrointestinal toxicity, mainly diarrhea, the predisposition to lactic acidosis in patients with advanced CKD, and B12 deficiency. And as we'll see, each of these drug classes, even the newer ones, have both positives and negatives, and these must be understood by prescribing clinicians. And we should always not forget that each of these drugs have a specific cost. Understandably, the generic formulations are now quite cost effective, whereas the branded products of the newer drug classes, specifically the DPP-4 inhibitors, GLP-1 receptor agonists, and SGLT2 inhibitors, are quite costly. As we mentioned, 2 newer drug classes, the GLP-1 receptor agonists and the SGLT2 inhibitors, have now been demonstrated to reduce MACE, major adverse cardiovascular events. And in addition, the SGLT2 inhibitors have been demonstrated to reduce heart failure outcomes and to reduce the progression of CKD. Insulin and sulfonylureas, in terms of cardiovascular events, are likely neutral. Metformin, as I alluded to before, may have a cardiovascular benefit, although I must say that the database in support of that statement is not very robust, as we'll see later on with some of the newer agents. In the UK PDS, a sub-study involving less than 1,000 patients suggested a 39% reduction in MI and a 50% reduction in coronary deaths in those randomized to metformin over conventional diet therapy. The TZD pioglitazone was also studied in the PROACTIVE trial. And here, traditional MACE, composite of CV death, non-fatal MI, and stroke, was reduced, relative risk reduction of 16%, although this was not the primary outcome of this trial, and therefore the results could only be considered hypothesis generating. In addition, hospitalizations for heart failure were actually increased by 41% in those randomized to the TZD pioglitazone. And this relates to this drug category's tendency to increase sodium retention in the distal nephron. In fact, when you look at the number of events saved in terms of MACE, they numbered 57, which precisely the number of increased hospitalization events for heart failure, 57. Kind of emblematic of the controversy regarding the TZDs in terms of the net benefit on the cardiovascular system. Recently, our group published the IRIS study, that's the insulin resistance intervention after stroke trial. We use pioglitazone to test its effect on cardiovascular events. This was non-fatal MI and non-fatal stroke in a group of more than almost 4,000 patients who had recent stroke or TIA. Importantly, these were not patients with diabetes, but they had insulin resistance. Most of them actually had pre-diabetes. And you can see that pioglitazone actually reduced the primary outcome by 24%. So I'm not sure the story is completely closed on pioglitazone. I personally believe that it does have an anti-atherosclerotic effect, but one needs to be cautious in terms of dosing and patient selection because of the heart failure risk. Although I will point out that in IRIS, we excluded patients with heart failure, allowed for dose adjustments, and we did not see any statistical increase in heart failure events. So for metformin, we can say that there is still a question mark, potentially a benefit, not a robust data set. And for the TZDs, I would say plus minus. The next series of medications that were studied in terms of a large cardiovascular outcome portfolio were the DPP-4 inhibitors, and they were found to be neutral. And as we'll see, the GLP-1 receptor agonists and the SGLT2 inhibitors are both demonstrated to be positive. This new information from the three last categories, DPP-4 inhibitors, GLP-1 receptor agonists, and SGLT2 inhibitors, comes to us because of the FDA guidance to industry that was released in 2008, more than 12 years ago. Here, the agency mandated that new glucose-lowering formulations coming to the US market had to document, at the very least, cardiovascular safety. And this emanated from several years of controversy regarding the link between glucose lowering itself and cardiovascular endpoints. These were the series of trials that emanated from the FDA guidance, again, at top 5 trials regarding DPP-4 inhibitors, in the middle 6 trials regarding GLP-1 receptor agonists, and at the bottom 5 trials regarding the SGLT2 inhibitors. As mentioned, the DPP-4 inhibitors were essentially neutral for MACE. So these drugs were felt to be safe, but not necessarily efficacious to reduce cardiovascular outcomes, although it's important to point out that controlling hemoglobin A1C has already been demonstrated to reduce microvascular outcomes. So there was some purpose to glucose lowering, but again, no additional advantage for the cardiovascular system. The next series of trials were from the SGLT2 inhibitor field, and let's review these in some detail. SGLT2 is a transporter in the proximal nephron that is responsible for glucose reabsorption. If the glucose concentration in the plasma, and therefore the glomerular filtrate, is less than 180 milligrams per deciliter, and these transporters are not overwhelmed, then there is minimal glucose excretion. However, if we block SGLT2 with a pharmacological inhibitor, we excrete 70 to 80 grams of glucose per day, which translates to 300 calorie loss per day. And just like I mentioned before with metformin, with the SGLT2 inhibitors, there are positives and minuses. So glucose lowering, low hypoglycemia, modest reductions in weight, about 2 kilos, modest reductions in blood pressure, about 4/2 millimeters of mercury, and a few additional benefits as well. Patients did have an increase in genital mycotic infections, mainly related to glucose in the urine. Initially, a question of increased UTIs, although that has not panned out in larger trials. Increased risk of diabetic ketoacidosis, mainly in very insulin deficient patients. but patients would perceive increased urination, and they could have a tendency for dehydration, a small reversible decrease in GFR, and a few other risks as well. And then all of these potential negatives were put into context when we published the EMPA-REG outcome trial in late 2015. And the most striking result from EMPA-REG, which tested the SGLT2 inhibitor empagliflozin versus placebo, a 38% reduction in cardiovascular mortality. When we look at additional SGLT2 inhibitor trials, such as the CANVAS program with canagliflozin and the DECLARE trial with dapagliflozin, one can see that there is an overall benefit, a 14% reduction in MACE from these trials in those patients with established ASCVD. If only multiple risk factors were present, the effect of these drugs were essentially neutral. When one looks at heart failure hospitalization, there was a striking reduction across these trials in those both with and without ASCVD. So the drug appeared to reduce heart failure hospitalizations even in those patients with multiple risk factors. When looked at differently, this is now dichotomizing patients based on the presence or absence of heart failure at baseline. You can see that there are additional benefits throughout the spectrum of heart failure risk. So very clearly, the SGLT2 inhibitors not only reduce MACE, but also prevent heart failure hospitalization. You can see that across the trials, the risk reduction is somewhere in the 30 to 35% range. This is a striking result because there had never been any glucose-lowering medication previously to reduce heart failure hospitalizations. In fact, as mentioned, the TZDs, if anything, increased heart failure hospitalizations. This led to significant interest from the cardiology community regarding the possibility that an SGLT2 inhibitor could be a heart failure medication. And this is the DAPA-HF trial that was published last year. This is a HF-ref study, so heart failure with reduced ejection fraction. Interestingly, we recruited patients both with and without diabetes into DAPA-HF. 26% relative risk reduction in the primary outcome of worsening heart failure or cardiovascular death. And importantly, when we looked at patients both with or without diabetes, there was no heterogeneity. So clearly, this medication helps patients with heart failure, even if they do not have diabetes. Just recently, empagliflozin was also studied in the EMPEROR-reduced trial. This is another HF-ref trial, and you can see that the point estimate being almost identical to DAPA-HF. And again, in EMPEROR-reduced, no significant heterogeneity based on the presence of diabetes. There are two HF-PEF trials underway, EMPEROR-preserved and the liver using empagliflozin and dapagliflozin, and will have results in 2021. Let's move now to the second drug category, the GLP-1 receptor agonists. This is regarding the incretin system. There are several signals that emanate from the GI tract under the stimulation of food to essentially turbocharge the pancreas to produce more insulin and also less glucagon. The hormonal signals involve two incretin hormones, GLP-1 and GIP. Just a reminder that the enzyme DPP4 metabolizes incretin hormones, and the gliptin drugs, the DPP4 inhibitors, sort of like a double negative, will inhibit that enzyme, allowing for increases in circulating concentrations of the incretin hormones. But the GLP-1 receptor agonists are pharmacological activators of GLP-1 receptors, and the relative concentrations are much higher with GLP-1s than with DPP4 inhibitors. As mentioned, the flozins, or the SGLT2 inhibitors, were mostly positive. The most recent result from ertugliflozin, called the VERTIS-CV trial, was actually neutral for MACE, although they were able to demonstrate a heart failure benefit. And the first of the GLP-1 receptor agonist trials, ELIXA, was actually neutral, although that was an acute coronary syndrome population. It may not have been the best population to demonstrate a benefit from a GLP-1 receptor agonist. And I'll review some of the next 5 GLP-1 receptor agonist trials in the subsequent slides. It all started with LEADER, looking at the daily GLP-1 receptor agonist liraglutide. And here, very similar to the overall MACE effect of 14% with the SGLT2 inhibitors, most of these patients had established CVD. I think it was about 80%, and the hazard ratio was 0.87, so a 13% relative risk reduction in MACE, and they also demonstrated reduction in cardiovascular mortality. This was a meta-analysis published by Marsico earlier this year. 3-point MACE across 6 or 7 trials was down by 12%, and a borderline statistical significance, a reduction in cardiovascular death to the same degree by about 12%. Now, there may be a bit more heterogeneity between these trials. LEADER, SUSTAIN 6 with liraglutide and semaglutide were both positive. Albiglutide was actually quite positive, but that drug is no longer marketed. And REWIND with dulaglutide was positive, and I put that in a bit of yellow highlight to remind me to tell you that REWIND was mainly a primary prevention trial. The majority of the patients in REWIND who were randomized to dulaglutide or placebo did not have established CVD, although they did have risk factors. So one could say that REWIND suggests that in contrast to the other studies, which mainly had secondary prevention in mind, these GLP-1 receptor agonists may actually prevent the new development of coronary artery disease or cardiovascular disease in general. As mentioned, Alixa was neutral, as was long-acting exenatide in Excel, but the majority of these trials have been demonstrated to be positive. And to wind up, let's talk about the impact of these trials on treatment guidelines from both the diabetes as well as the cardiovascular communities. These, as you recall, were the guidelines from ADA and EASD that I showed you before from 2015. Notably, this was before any of these large CV outcome trials were published. So there was nothing in this set of guidelines guiding us regarding the impact of these medications on the cardiovascular system. We might say this was a very glucose-centric guideline. It was simply driven by hemoglobin A1C. And I might say that these were indeed, even though it was only 5 years ago, these were indeed the dark ages of diabetes therapy, because we were in the dark in terms of the impact of these medications for the most part on the cardiovascular system. So the renaissance, if you will, for diabetes treatment from, again, the two main organizations in the world, the American Diabetes Association and its sister organization from Europe, the European Association for the Study of Diabetes, the EASD, came up with these new sets of guidelines. This one published in 2019. It's a bit overwhelming, but for a point of discussion today, I just wanted to focus on the left-hand side of this slide. After metformin monotherapy, then the question that is asked, or should be asked by the clinician, the prescribing clinician, is whether the patient has or is at high risk for ASCVD, CKD, or heart failure. Well, why is that? Well, let's blow it up. If ASCVD predominates, then preferably a GLP-1 receptor agonist or an SGLT2 inhibitor could be used in addition to metformin based on the effect of these drugs on MACE. If heart failure predominates or CKD, hold the CKD notion just for a second because I did not review this specific data for you, but let's remember that the heart failure effect of the SGLT2 inhibitors are significant. And therefore, if heart failure predominates, then the preference would be for an SGLT2 inhibitor. There's also a effect of the SGLT2 inhibitors on the progression of CKD, topic for another lecture perhaps. But if CKD is present, as long as there is substantial GFR still present where the drugs can be used, they shouldn't be prescribed at least to date under 30 milliliters per minute. But in mild to moderate CKD, then an SGLT2 inhibitor would be the preferred agent. Importantly, the most recent tweak to the guidelines mentioned that these choices of agents should be considered independently of baseline A1C or the A1C target. this is a radical departure for the diabetes community. They're saying that after metformin, even if you're under good glucose control, consider adding these medications simply for their cardiovascular or kidney benefits, much less glucocentric than in the past. Now, cardiologists see diabetes patients with ASCVD actually much more commonly than diabetologists. There are many more of you than us. And therefore, the cardiologists have been interested in developing their own guidelines for the management of type 2 diabetes. And I think this is actually welcome. These are from the ESC. And the bottom line is that if diabetes and ASCVD are present, then patients should be offered an SGLT2 or a GLP-1 agonist even before metformin. So this is pushing the envelope a little bit, suggesting that foundation therapy may no longer simply be metformin. And obviously, if they're already on metformin, then you would add one of these drugs. On the latest iteration of the diabetes guidelines, they do mention patients at high risk that this could also be considered, that you don't need necessarily to have established CVD. The ESC takes us a step further, denoting patients either at high risk or very high risk. And as you can see here, this incorporates many of our patients with type 2 diabetes. Well, allow me to conclude. Correcting the major metabolic defect in type 2 diabetes, namely hyperglycemia, has had very little impact on its major complication, cardiovascular disease. As regarding older drugs like metformin, SUs, insulin, and the TZDs, these drugs have either been demonstrated to be neutral or have controversies regarding the risk to benefit ratio. Given these and related controversies, in 2008, regulatory agencies began to mandate large cardiovascular outcome trials for new diabetes medications. The first of these trials with the DPP-4 inhibitors proved neutral, safe but not effective to reduce cardiovascular events. In contrast, two newer drug classes, the SGLT2 inhibitors and the GLP-1 receptor agonists, have now been clearly demonstrated to reduce major adverse cardiovascular events. The SGLT2 inhibitors, in addition, appear to improve heart failure outcomes, even in the absence of diabetes in patients with HFrEF. So these positive trials over just the past 4 or 5 years are leading to a rapid evolution in our approach to managing type 2 diabetes and should be of enormous interest to the cardiovascular community. Thank you so much for your attention.
Thank you, Dr. Idzuki. Outstanding, outstanding presentation. Very dense, but so well simplified and so well presented. Thank you so much. So now in our question answer session, I've got a large list of questions here, but somehow or the other, I think I will have to pick up only a few because we have a very short time for us. Dr. Fuster, you tried not to talk about the genetics, but people have been asking the questions about genetics to you. And not only that, next year the topic will be on genetics, but we probably might like to give them a teaser as to what do you think about genetics, specifically when we say that it is a disease of lifestyle abnormality and behavioral abnormality. But then does genetic really have to play? Number one, and number two, that do these environmental changes, quite like smoking, oxidative effects, the diet and lack of exercise, do they also influence the genetics or so-called the epigenetic phenomenon? So I think it's a loaded question, Dr. Fuster. Probably people want to hear from you about genetics also this year itself.
And basically, in this rating, what we found is that the highest incidence of mutations actually were related to coronary artery disease survivorship or mortality. And the question is how this compared with the conventional risk factors. And this is the story that is important. First, genetics have very little to do with what we usually talk about family history. Family history of coronary artery disease can be related to father was a smoker, and then you develop coronary disease and you say it's genetic, and it's not. So we have to be very careful that genetics should not be ascribed to just family history. That's the first point. Second, of patients with coronary artery disease, about 50%, there is no question, have a genetic background of the genes that we mentioned to you. But what is fascinating is when you put environment versus genetics, the environment is the winner. And that is, you can have a high genetic score, as I mentioned, but if at the same time you are a smoker, or you have, for example, you are obese, that particular environmental factor probably plays a more important role than the genes. So summarizing, genetics are very important, but the environment appears to be more important. And that is, the question is what the environment means. There is a genetic factor on the environment, which is the question that you mentioned. Yes, there are epigenetics, and that is the environment that we are, and particularly during fetal life and related to the, the pregnancy. That environment is very, very important. Is the mother or the future mother is a smoker, or the future mother is obese, and so forth, the children have a predisposition for coronary artery disease once they get into the smoking environment or they get. It's very fascinating. So in summary, what I can say is a huge amount of information. First, that family history doesn't mean genetics. Second, genetics are probably important in about 50% of people who develop coronary artery disease. But environment appears to be more important than genetics. And finally, part of the environmental aspects that play a role have a genetic, epigenetic background that was acquired during pregnancy or during other exposures that I can say. This is a summary of a huge topic that certainly if you invite me next year, I can concentrate on this.
Thank you, Dr. Fuster. There is another question for you, and that is from Paul Carreon. And he, first of all, congratulates you on your new hypothesis of Alzheimer's and other senile dementias being due to the cerebrovascular disease and not due to the neuronal degeneration, or at least predominantly due to the vascular phenomenon. He's asking, if it is a vascular phenomenon, then why is it that the coronary artery disease is more common as compared to dementia?
Well, first of all, we have to be very careful here. To put together now coronary artery disease and Alzheimer's is an incredible breaching, which I'm very careful, and there is a gap. But the things that we are saying is the following. Alzheimer's 100 years ago said, my disease is a pathology, is a vascular disease. And we are not entirely sure if he was talking about a disease that relates to the risk factors that I mentioned, or whether it's a disease that's related to a thrombotic phenomena by beta amyloid that I mentioned. And this is something that we are investigating. Now, to go into coronary artery disease, and what is the relationship between coronary artery disease and Alzheimer's? We can only say that the risk factors that affect cardiovascular disease are affecting the microvasculature of the brain. And from then on, we have then to move to Alzheimer's, which is a very complex disease, which the way I see it today, and is all hypothetical, probably 50% or 75% has to do with a neuronal problem that has been investigated over the 100 years and with no therapies yet. And about 25% may be related to a vascular component. And the vascular component are the risk factors that affect coronary disease or maybe a thrombotic phenomena due to beta amyloid. This is where we are in the study that we undertook in 1,000 people, about 500 with original cognitive dysfunction, about 500 with original cardiovascular disease, coronary disease, and will tell the answer to the question presented to me, at least an opening door to the answer in the next 3 years.
Thank you. Dr. Achenbach, the question from Dr. Olavale Olatunji. He has a two-part question here. The first one is that you said that there is the ECG, exercise electrocardiogram, is no longer necessary. But he says that our insurance companies still force us to do them, though I think they are not very useful and it has only 50% of sensitivity. So how do you reconcile that fact?
Well, this is an excellent question. Exercise EKG is used a lot. In Europe, it is used extensively. The fact is that the data simply shows that the accuracy is not as good. So if you have another testing method available, angiography, if the patient is suited, or stress testing based on an imaging test, stress echo, SPECT, stress MR, those should be preferred over exercise testing. Nevertheless, exercise testing is not completely useless. Exercise testing modifies the pretest likelihood substantially. A normal exercise test and a pathological exercise test should be taken into account when you make your assessment of pretest likelihood of the patient. It is a balance that was, tried to be achieved in these guidelines, knowing that not everybody can, and not in every patient we can perform an imaging stress test. In most parts of the world, that's simply not possible. So stress EKG remains in the guidelines, not as the class 1, but still recommended to modify your pretest likelihood. You have to know about the limitations. You have to know that it needs to be performed well in order to be used full at all. It remains in the guidelines, but we just have to accommodate for the fact that the imaging-based stress tests are simply more accurate.
His second question is, what about the coronary calcification in an asymptomatic person?
Yes, I mean, this is another excellent question because it opens up a new area, and that's the risk stratification of asymptomatic individuals. I mean, this is about prevention. This is about the question whether patients should be on risk-modifying therapy or not. This is not so much about diagnosing symptomatic coronary artery disease. We know that coronary calcification is associated with the future risk of cardiovascular events, but it's not associated very closely with ischemia associated with coronary artery stenosis. So in the setting of working patients up for coronary artery disease that causes symptoms that potentially needs to go to revascularization, the calcium test is not extremely useful. You could argue that if there's absolutely no calcium, then it's less likely that patients have coronary stenosis, but particularly in young individuals with recent onset chest pain, you can have stenosis even without calcium. So this is why the calcium score does not play a very prominent role in the guidelines for coronary artery disease.
Another question is from Rosemary Carreras for you, Stefan. She says that you have, as you presented in your table, that the PET and CTA have the similar sensitivity and specificity for all practical matters, the same diagnostic accuracy. So do they have any differential role that, or preferred role in the patients with chronic stable coronary disease?
Yes, I mean, we have to realize that PET and CT angiography look at different things. PET looks at perfusion, so it's an ischemia test, and it's also very useful for variability. So if you ask me, probably the more valuable test, particularly when a workup for ischemia, is certainly the PET scan. However, at least in the environment where I work, you cannot perform PET scanning in a large number of patients. It's simply too elaborate, too expensive, and absolutely impossible to use this as the basis for our stress testing. So these two tests are looking at different things. There are also different difficulties associated with performing them, and not one can replace the other. But in all environments that I know, using PET as the first-line test would probably usually not be possible.
Thank you. And from same person, the question for Dr. Inzuki. What is your HbA1c goal in patients with coronary artery disease / myocardial infarction vis-a-vis heart failure?
Thank you for that question, and it's a pleasure to be here. I think that the discussion about HbA1c target needs to incorporate the treatment of the patient in terms of whether the strategy that's being utilized can induce hypoglycemia. So that if you're using two drugs, for instance, metformin and let's say a GLP-1 or an SGLT2, and you can get the hemoglobin A1c down to 6.8% without any risk of hypoglycemia. It's when you use insulin or perhaps sulfonylureas where you have to be a little bit more judicious in terms of protecting the patient from hypoglycemia, and therefore a more moderated hemoglobin A1c target may be advisable in high-risk patients to avoid potential induction of cardiac ischemia, arrhythmias from hypoglycemia. And therefore, a hemoglobin A1C target in the mid 7% range may be reasonable. It's important to note that at least in the SGLT2 inhibitor trials, specifically EMPA-REG outcome, we looked at this specific notion as to whether hemoglobin A1C was at all important in the impact of empagliflozin on the cardiovascular outcomes, MACE, cardiovascular mortality, heart failure, hospitalization, and the answer was no. So even those patients that did not experience any significant reduction in their hemoglobin A1C, the drug still appeared to be efficacious from the cardiovascular standpoint.
Thank you. The next question is, why are we stuck with the metformin as the starting agent? Why not start with the SGLT2 or GLP-1?
It's a great question. It's a controversial question. I think endocrinologists are still in a love affair with metformin. It is an old drug that's been out since 1995 in the US, certainly longer in Europe and South America and Canada. It is very inexpensive, $4 per month in most parts of the US. It may have some cardiovascular benefits. Remember, those trials were done in the 1980s and 1990s, suggesting a cardiovascular advantage to metformin over other drugs such as sulfonylureas. Unfortunately, we'll never retest metformin in a large CV outcome trial, so the evidence base is much larger with SGLT2s and GLP-1s. I think it's more of an academic question than a practical question. Metformin has very few side effects that are long term. If you can get beyond the first week or two with a little bit of loose stools, it's very well tolerated. And many patients will require 2 medications to achieve their hemoglobin A1C target. And if you read the ADA EASD guidelines closely, it says that irrespective of the A1C, you should add one of these drugs anyway. So that essentially implies that all patients with CVD should be on combination therapy. So I think it's become more of a semantical discussion than it is a practical discussion. Some groups are recommending initial therapy with metformin and an SGLT2 inhibitor. But suffice to say that it's hard to argue with the ESC guidelines, which say that metformin does not deserve its place on the throne of diabetes management. And maybe we can start with an SGLT2 or GLP-1. But the cost implications should also be considered because these medications are 100 times more expensive than metformin.
Great. And then there are a couple of questions for me. The first question is what is the role of tocilizumab? And the answer to that is that the study, the phase 3 study, which was just recently reported by Gilead, the drug company maker. So they presented that there was not much of a difference except the fact that there was an earlier discharge from the hospital. And the study that came from Italy that demonstrated that the people who died on tocilizumab, although that was not a randomized study, that was significantly lower as compared to the people who were not treated with the cytokine inhibitor. So I would not be able to say that there is a major understanding in terms of where exactly should it be started and how should it be given. But so far, the data are not unequivocally conclusive. And the second question is, what about the changes at 6 months? Do we need to follow everybody until 6 months? And would we need to do the magnetic resonance imaging in all our patients? So the answer to that is yes, that the abnormalities by MR has been shown up to 6 months. And it has been demonstrated that there is a likelihood of edema or a likelihood of increase in the extracellular fraction, even way after the antigen is gone, and whether or not the antibody is present in these people. But we need to have that balanced view here, because we do not know what happens in all the viral infections. We do know that the viruses affect, there are multiple cardiotropic viruses that they do affect the heart, but we have no idea as to what happens. Do they also cause that much of edema? Do they really lead to so much of a permanent abnormality in these cases? So long-term follow-up would be needed. Essentially, if there is an edema which is caused by them, we need the lymphatics and all to mature enough so as to remove the edematous collections from the interstitial spaces. So I think the best thing would be to follow them up rather than getting too excited about it. We do know that in the athletic or the professional athletic areas, there has been a significant concern about this, but the most important thing would be the follow-up data here, and as to how it evolves, how it disappears, and also to be able to compare them with the patients who have influenza or other viral infections, whether they also lead to something similar, and whether this is just a simple consequence, or does it have a pathogenic role for future, would need to be established before we can say anything with certainty. So I think there is one more question that just came for Dr. Inzuki, that should we be giving the SGLT2 agents prior to or after an imaging or an interventional procedure that requires contrast?
That's a great question. I don't think we have any information on that. A study would need to be done. The way the SGLT2 inhibitors presumably work, although there has been some controversy recently about this, is similar to the way a RAS blocker works in terms of reducing glomerular pressure. Now, the RAS blockers work in the efferent arteriole, whereas the SGLT2 inhibitors presumably work in the afferent arteriole. But the net effect of both of these agents is to reduce intraglomerular pressure. We've looked at whether cardiotoxic medications such as NSAIDs, combined use with RAS blockades, various diuretics can accentuate the potential for these drugs to lead to acute kidney injury, and we don't find anything. So if anything, AKI is reduced surprisingly in patients who are given these medications. I was very concerned when we set up DAPP-HF that because the vast majority of these HFrEF patients were on loop diuretics, that we'd see a lot of volume contraction, adverse events, lots of AKI. That did not pan out. If anything, AKI events, even in that HFrEF population, were less common in those taking SGLT2 inhibitors. So there may be a preventative effect of the SGLT2 inhibitors in the setting of some potential injury to the kidney, but I don't have any data on whether contrast-induced nephropathy may be mitigated or accentuated.
Thank you. There's a question came for Dr. Ichipuria. What are the strategic decisions of the American College of Cardiology for the growth of the FITs and young career or the early career faculty members? So there is anything new that is coming, and how exactly should they try and avail it?
Well, I mean, there's a early career section as well as a fellows and training section that they can join. There's also a lot of leadership programs. There's a leadership cohort. There's multiple leadership cohorts, actually. One that is for people that want to be researchers, one that is just a leadership cohort. And we're actually in the 4th cycle of that leadership cohort. And each year they have anywhere from 20 to 25 members of that leadership cohort that help them go through a training program. So there's been a lot of work done in the pipeline for early careers and fellows in training. So I think there's a lot of opportunities. They need to go on the acc.org website and take a look. But lots and lots of opportunities for those folks.
And one question which you may not like to answer, or you may like to answer it very diplomatically, Dipti. The question asked is, how do we make AHA and ACC into a one combined organization?
Well, I mean, I think that the goal, the mission, vision, and the goals of the two different organizations are somewhat disparate a little bit. I think that there are lots of common grounds, as we have found when we do the guidelines, for example. That's why the ACC-AHA combined guidelines. I think that those are things that need to have further conversations. I think that the leaderships need to get together and continue to have those conversations and continue to find the common ground, so that we may find that maybe we're more similar than we are different. So I think those are good goals to have in the future. I'm not sure that's something that's going to happen in the next year during my presidency, but I certainly think that that could be something we could work towards.
Very well answered, and that is why you truly deserve to be the president. And the next question is to Dr. Fuster from Dr. David Harnick. And it is that why people on anticoagulant and antiplatelet agents develop Alzheimer's disease?
Well, excuse me, why every patient die? You know, I think I gave the answer.
Yeah.
You know, the life doesn't depend from one particular variable. It depends on thousands and thousands. And actually, this goes back to machine learning. One of the things that artificial intelligence is going to tell us are variables that we never thought were important and are really important. So I'm not answering your question, but saying that the number of variables that play a role in any manifestation of cardiovascular disease or mortality is much larger than what we usually think about it. And that's where machine learning is going to tell us a lot.
Okay. Dr. Inzuki, any trials with both GLP-1 and SGLT2?
Not that I'm aware of. It's a good question. It's a very expensive combination, probably approaching $1,500 per month. There are small trials looking at efficacy in terms of glucose lowering and effects on body weight. The body weight appears to be additive, not synergistic. The A1C effect appears to be less than additive, as is often seen when you're combining glucose lowering medications. The real question, which is the implication of the question, I think, is whether there is either an additive or a synergistic effect on cardiovascular events. There could be, right? Because the effect of the GLP-1s appears to be mainly through an anti-atherosclerotic process. At least that's the inference from the clinical trials. Whereas with the SGLT2 inhibitors, there's many different theories. The event curves diverge almost within 1 to 2 months regarding heart failure hospitalization and CV death, suggesting that there may be an abrupt hemodynamic benefit from using an SGLT2 inhibitor, whether that's effects on afterload and preload. I know cardiologists don't like that because they point to the fact that other diuretics have not had such an effect on clinical outcomes. But there may be the opportunity for having these drugs in combination working differently on the cardiovascular system and therefore being additive or potentially even synergistic.
Thank you. I apologize, I forgot to give the credits for these questions. This question was asked by Dr. Harvey Kramer, and the earlier question on why not start with the SGLT2 instead of the metformin was by Dr. Ali Ajmal. So I think Dr. Sharma has been sending me the text messages that I need to end the session here.
But if I can say one thing, there are many other questions there. We will send those questions to the individual faculty, and then answers will be posted along with the rest of the meeting. I think that probably will be the best way.
Thank you.
There's still many more questions there.
Okay, so I would like to thank, and do not forget that there is another session coming immediately after my last announcement here, and you would really like to attend that particular talk. So we all thank you for participating in this top 10 advances in cardiology, in clinical cardiology, which is our annual feature, and we look forward that you enjoy today's later session as well as tomorrow's session, where you would be getting 5 lively talks tomorrow also. You will receive an email from CME after the conclusion of the course on Sunday with instruction on how to take the evaluation and receive your CME certificate. The course will be archived in the coming weeks for, as I said earlier, on the ccclivecases.org/top10topics or on the CCC Live Cases YouTube channel. And then please visit the virtual exhibit hall featuring the booths of our conference sponsors. And we look forward to seeing you in our next session as well as for tomorrow. So our next talk, which I think I'm really waiting with the bated breath here, is from Sam Tsimikas, a very close. But this talk is a non-CME accredited talk and hence needed to be separated from the morning session because Dr. Tsimikas, who is an astute scientist, and a very well-known and sought-after clinician, has recently joined as a vice president of the global cardiovascular development at Ionis Pharmaceuticals, and that is the reason that we needed to separate it out. But Dr. Tsimikas is professor of medicine, director of vascular medicine at UCSD. He continues to see the patients there. He continues to hold his clinics, does his interventions, teaches. And he has worked extensively on atherosclerosis and molecular medicine, and has specifically been involved in the lipoprotein a. He is the first person who first started the lipoprotein a clinic, something which has been kind of defied us and defied the management. But now, with the new management that he came up with, collaborations with Dr. Wisdom, Steinbergs, and some of the stalwarts in the field of lipid management are likely to see the light of the day very soon. So the topic for Dr. Tsimikas is subcellular therapeutic targeting of common lipid disorders. So Dr. Tsimikas, we are honored to have you here. Thank you.
Hello, this is Dr. Sam Tsimikas, and I'm happy to present this lecture on subcellular therapeutic targeting of common lipid disorders. I'm from the University of California, San Diego, and these are my disclosures. Lipoproteins that are genetically associated with cardiovascular risk and also amenable as therapeutic targets are shown in this slide. These include ApoA of lipoprotein a, ApoC3, and angiopoietin-like 3, as well as ApoB of LDL particles. Now, this is an area that's been rapidly growing. As you can see from this slide, there's been several key lipid-targeted antisense oligonucleotide publications since 2014 in some of the top journals in cardiovascular medicine. Now, when we talk about RNA therapeutics, there are really three classes, and today we're going to focus mostly on antisense technology. But just so everyone understands the distinction, antisense is single-stranded modified DNA, and it's modified in a way that can be used as a drug. siRNA is double-stranded, so it requires two RNA molecules to be used as a therapeutic target. And there's a third therapeutic class, which is not used very commonly, which are aptamers, which we're not going to discuss today. The two mechanisms, antisense and siRNA, have slightly different mechanisms, but ultimately work in the same way in reducing protein production. Now, this is a relatively young field in its infancy. These are the only drugs approved that are in the realm of RNA therapeutics. And you see here, there are really only 4 companies so far that have successfully approved drugs, including Ionis, Sarepta, NS Pharma, and Alnylam. Now, antisense drugs target RNA via Watson-Crick base pairing, and they use a mechanism of ribonuclease H1 or RNase H1 mediated degradation as a way to prevent protein production. And as you can see here on the slide, you have DNA that gets transcribed to mRNA. The mRNA then will be translated to protein. And the mechanism of action of these drugs are quite elegant. The drugs are injected subcutaneously. They go into the target of interest or the cell of interest. They go into the nucleus, and then they bind their mRNA target in a complementary fashion. And then once this duplex is formed, RNase-H1 recognizes it and cleaves the sense strand. So this strand right here that would make protein. The antisense strand can then actually go back and bind to another mRNA molecule. And for this reason, these drugs are highly long-acting. Now, when you degrade the mRNA, you actually end up having less protein. And the reason why a lot of people love this mechanism and why it's so elegant is that you never produce any protein in the circulation that you now have to remove. For example, as if you would use an antibody to bind them. Now, another advance has been the so-called GalNAc targeted antisense molecules, which increase potency 20 to 30-fold. And there's a receptor in the hepatocytes called acetylglycoprotein. This binds a modified sugar called N-acetyl-galactose. You can then bind this molecule onto your antisense molecule and inject it. And this will eventually end up into the hepatocyte, get internalized. The GalNAc is cleaved off, as you can see here. The antisense molecule then goes into the nucleus and has the effect I showed you earlier. When you do that, if you take the molecules that don't have the GalNAc and you add the GalNAc, and you now need less than 20 to 30-fold drug. So in that regard, the doses are much lower, and of course the efficacy is maintained, and therefore the therapeutic index is much better with this approach for the liver-targeted areas. I'm going to briefly mention LDL here, and inclisiran is a siRNA that targets PCSK9 mRNA. There's been several trials that have been completed. This drug is not approved yet, but it's in the regulatory pathway for being approved for lowering LDL cholesterol. And you notice here, when this drug is given, you get about a 50% reduction in LDL cholesterol. This is 2 different trials. And an advantage of this drug that it needs to be injected twice a year, which will offer convenience for lowering LDL cholesterol. Now, I'm going to take you through 3 other targets, LPA, ApoC3, and angiopoietin-like 3, which are novel targets, and none of these have an approved drug except ApoC3 and Waylivra in the European Union for a very rare condition called familial chylomicronemia. But I'm going to start with Lp(a) and review this and take you up to date on the trials with this target. Lp(a) is composed of an LDL-like particle to which is attached an apolipoprotein a, which is derived from plasminogen. It contains oxidized phospholipids in both the ApoA and the lipid phase of the molecule. The levels are genetically determined at birth by the number of these kringles that are present on ApoA. Elevated levels can cause cardiovascular disease through 3 mechanisms: atherogenicity through its LDL moiety, antifibrinolytic activity through its ApoA component, and pro-inflammatory effects through its content of oxidized phospholipids. The 2 key phenotypes are cardiovascular disease and aortic stenosis, and there are no approved pharmacological therapies at this time for it. Lp(a) was discovered in 1963 by Carrie Bird. As I mentioned, it's derived from plasminogen. There are multiple alleles of ApoA that vary according to the number of Kringle 4 type 2 repeats that you see here in yellow. And so there are over 40 different isoforms among the population that are genetically determined from each parent. In terms of its phenotypes, it causes all the cardiovascular phenotypes that are known, including aortic stenosis, but it's not associated with other non-cardiovascular phenotypes. Its metabolism is well known for the most part. Primarily, it is synthesized in the liver, and most of the plasma level is due to liver production. There are a variety of receptors that we're not going to discuss in detail that seem to hurt. The quantitative contribution of each one of those is not well defined. The plasma levels of LPA are a combination of what each chromosome essentially produces. And so you see this patient here has a small number of clinical 4 type 2 repeats, 10. This patient has 25. Each one of these is associated with a certain plasma level. Because this has lower number of repeats, the liver can make many more particles. So when you eventually look in the circulation, the red here is the contribution of this allele, the blues from this allele. This is 60, this is 10, so the plasma level ends up being 70 milligrams per deciliter. So unlike other proteins, this has different contributions from each allele, but ultimately it's the LPA level in the plasma, irrespective of which allele produces it, that drives the risk. It's a very prevalent risk factor. Level 60 milligrams per deciliter or higher are present about 20% of the population. So that's 64 million estimated in the US, 150 million in the EU, and 1.4 billion globally. Now, when you look at the genetic determinants of CAD, you're well familiar with most of these genes in the lipid metabolism and inflammation. This is 9p21, LDL receptor, PCSK9. Notice quantitatively, the LPA gene is the most potent risk predictor when you look at it as individual genes. There's a wide level of evidence for this being atherogenic, including primary care settings. You see here meta-analyses, Mendelian randomization, gene association studies. The risk seems to start at about 30 milligrams per deciliter, and it's approximately linear in all of these studies after that threshold. There are also data now on statins, LPA. This is a meta-analysis that we performed in over 29,000 patients, 5,751 events. Notice here that the level, again, is linear at about 30 milligrams per deciliter or higher. This is now data on PCSK9 inhibition from the Odyssey outcomes trial. And depending which endpoint you look at, notice here, there's about a 25% higher risk of MACE within this highly well-treated population. Notice the fourth quartile is associated with the highest risk compared to the first quartile of LPA levels. And the fourth quartile here is 59 milligrams per deciliter or greater. And recall that the normal level is greater than 30 milligrams per deciliter. Now, Lp(a) is also associated with aortic stenosis, in particular through its content of oxidized phospholipids. I will not review this in this talk, but these are 7 recent studies that are contributing to the database for Lp(a) and oxidized phospholipids being a contributor to calcific aortic valve stenosis. Now, we know that these oxidized lipids and LPA are present in atherosclerotic plaques. This is a saphenous vein graft intervention. And you see here the lesion before, and you see it afterwards that's treated with a stent. Notice the atheroma. This atheroma was then tested. And notice here with a mass spectroscopy, you can find very copious amounts of oxidized phospholipids in this. This is a separate patient. Notice here, this is a histology study from a patient that died. Notice the LPA, the oxidized LDL, and the oxidized phospholipids. That's very, very strongly prevalent in these large, bulky atheromas. Oxidized phospholipids predict outcomes. This is 8 studies in both primary and secondary prevention settings, and these seem to drive much of the inflammatory risk from Lp(a). This particular test is called oxidized oxidized phospholipids per ApoB, and this is now commercially available for clinical applications. Now, PCSK9 inhibition is not highly effective in patients with high LPA. This is a study called ANICH-COW. There was only a 14% reduction in patients with LPA level over 50 milligrams per deciliter. And notice there's no difference actually in the FDG uptake with PCSK9 inhibition in these high LPA patients, suggesting that one needs to reduce Lp(a) to have some effect on the vessel wall. Now, if you're seeing patients in clinic, does LPA, measuring LPA affect how you risk classify those patients? And the answer is yes. These are 2 papers published in JACC. And bottom line is in an intermediate risk category of patients, you reclassify all these patients that have different colors here, and that's approximately 40% of this group, which is about 4 out of 10 patients that you might have go into a lower risk category because their LPA levels are low, or they might go into high risk category if their LPA levels are high. Now, Lp(a) is finally made into many guidelines. There are now 6 guidelines, and I don't expect you to read this, but this is just a summary of those guidelines. And the most recent ones that should have a major effect in LPA testing are from the European Society of Cardiology and European Atherosclerosis Society, where they recommend measuring LPA at least once in every adult patient's lifetime to identify those with highly elevated LPA levels that might have a CVD risk equivalent to familial hypercholesterolemia. Now, along with that, an ICD-10 code is now available. So when you see a patient in clinic, you can actually diagnose them with high using these 2 codes. Okay, so let me take you through now where we are with this target. There's a phase 2 study which just completed and published. The drug was called Exia ApoA-LRx. It's now called pelacarsen with a generic name. This is a phase 2 trial. They used 5 doses and dose regimens. Patients were treated for 6 to 12 months. The primary endpoint was LPA lowering with some additional endpoints. And here is the main findings of the study. This is placebo, and this is 20 milligrams every week, equivalent to 80 milligrams a month. Notice a mean 80% reduction in LPA levels with a nice dose-dependent reduction. Importantly, if you ask the question, what percent of patients get under 50 milligrams per deciliter, which is the recommended threshold for having minimal risk? Notice here, 98% of the patients achieve this level in this study. So that suggests that you can pretty much get everybody to go with this particular drug, and it would also be an excellent drug to use testing the LPA hypothesis. Now, in this study, there were also additional beneficial biomarker changes, including an oxidized phospholipids that you see here, LDL cholesterol, as well as ApoB100. All were significantly reduced, and some substantially. These are the absolute values in the highest dose cohort. Based on this, Novartis has now started the LPA Horizons cardiovascular outcomes trial. The idea here is you take patients who are in the red, who have greater than 70 milligrams per deciliter, and they anticipate to have a median LPA of 90 milligrams per deciliter or 225 nanomoles per liter. They will be treated with pelacarsen 80 milligrams sub-Q monthly versus placebo on top of standard of care medical therapy otherwise, which can include statins, PCSK9 inhibitors, and ezetimibe. And they will be pushed into this green zone where they'll be mostly under 50 milligrams per deciliter. And the primary endpoint is going to be actually a co-primary endpoint, time to MACE in people with LPA over 70, and a second co-primary endpoint, time to MACE in people with LPA over 90. The trial is anticipated to have a median follow-up of 4.2 years, so very robust, a minimal follow-up of 2.5 years, and 993 events. So you can think, I think of this trial as, for us, that was the first statin trial. It will be robust, well-powered, in substantial duration, and it will finally test the LPA hypothesis. Okay, I'm going to switch gears now to ApoC3. ApoC3 is a small lipoprotein. It's present in all triglyceride-rich lipoproteins, but also present in LDL and HDL. It's made by the liver. It helps to both clear these large yellow particles and also small particles. It helps to prevent clearance of those particles because it inhibits some interaction with the receptors, but it also interferes with lipoprotein lipase activity so that it actually prevents their remodeling. Epidemiology studies have linked high ApoC3 levels to cardiovascular risk, and genetic studies have linked loss of function mutations in ApoC3 to a 40% reduction in triglycerides and a corresponding 40% reduction in cardiovascular disease. Therefore, it makes it an excellent target for both rare disorders of chylomicronemia and also common disorders of cardiovascular disease. This phase 2 trial was just reported at the European Society of Cardiology. 140 patients were randomized to these 4 doses or dose regimens along with placebo. This is the most equivalent. They got a minimum of 6 months and a maximum of 12 months. The primary endpoint was the fasting change in triglyceride levels. And here is the final, here's the primary endpoint, placebo, trending to an increase, and then the dose 50 milligrams once every 4 weeks. You see here a 60% reduction in triglycerides, which is approximately twofold higher than current standard of care. The secondary endpoints showed that there was a significant reduction in ApoC3 that was dose dependent, up to a 60% reduction in VLDL cholesterol, reduction in non-HDL cholesterol, reduction in ApoB in some of the cohorts, and an increase in HDL and ApoA1. Now, importantly, similar to the ApoA study, the question was asked, how many patients can get to a threshold under 150 milligrams per deciliter, which is felt to be optimal level. And notice here that 91% of patients in the highest dose achieved an triglyceride of less than 150 milligrams per deciliter. Again, speaking to the potency of this particular approach and the ability to get most patients to goal. So what are the next steps with this drug? A phase 3 study in familial chylomicronemia syndrome initiated. These patients get pancreatitis. They tend to have triglyceride levels in the thousands. There will be additional, and they have a specific genetic abnormality in the lipoprotein lipase gene family. A second indication for multifactorial chylomicronemia syndrome. These are the patients that have multiple different reasons for very high triglycerides and also have pancreatitis as their problem. Another study will be planned for patients that have triglyceride levels of 500, and eventually a cardiovascular outcomes trial in the more modest elevations of triglyceride levels. Okay, to finish up with angiopoietin-like 3, this is another lipoprotein that inhibits lipoprotein lipase activity, and therefore it's affecting both triglyceride and LDL metabolism through two pathways, one through the LPL activity, but also reduces output of VLDL. So when you look at genetic abnormalities of angiopoietin-like 3, these patients have low triglycerides lifelong, low LDL, but interestingly, they'll tend to have also low HDL cholesterol, probably because this also affects endothelial lipase. Genetic and epidemiology studies are consistent with this being an atherogenic risk factor, and therefore it's also an excellent target for therapeutic intervention. This study was just published in European Heart Journal last month. This is another phase 2 study, 105 patients, 3 cohorts. These are the monthly, weekly or monthly doses. Again, the duration of follow-up or treatment and follow-up. And this study included difficult to treat patients that had to have both 3 things: high triglyceride levels, type 2 diabetes, and hepatic steatosis by MRI. So you can consider these as your most difficult patients to respond to these therapies. Notice here the baseline characteristics that are shown. Middle-aged patients, high BMIs, hemoglobin A1C controlled around 8, 17% hepatic fat fraction, and triglyceride levels 300 plus range. This is the primary endpoint, up to a 53 to 47% reduction, depending on which dose is given in the primary endpoint, which is the percent triglyceride reduction from baseline. And these are the secondary endpoints looking at angiopoietin-like 3, total cholesterol, VLDL cholesterol, non-HDL cholesterol, ApoB, and importantly, ApoC3 was also significantly reduced. So this drug tends to reduce most of the atherogenic lipoproteins that are present in patients. Now, this trial wasn't necessarily designed for a precursor to phase 3 because it had these very complex patients. However, Pfizer is now initiating a phase 2b study that is specifically geared to patients with cardiovascular disease and elevated triglycerides. And this is ongoing, and this will choose the dose for the phase study, which will start probably end of next year. So with that, I'd like to stop and acknowledge all of the folks that were involved in these trials at Ionis, Axia, Novartis, Pfizer, as well as academic collaborators that you see on this slide. Thank you very much.
Thank you very much, and truly grateful to all these speakers in the CME and the non-CME session. And look forward to seeing you in the booths where you could visit the exhibit halls, and also looking forward to seeing you tomorrow morning for another exciting day or another exciting half day of the top 10. And we do hope that you really liked it. More than 280 people registered and innumerable online otherwise. Thank you and look forward to seeing you tomorrow. Dr. Sharma, would you like to say anything?
Thanks. It's a stellar program and very well done. This was our first official Zoom meeting. We had given lectures in Zoom, but to have this organized with the top level speakers and putting everything together with the Danny and Madden Box and Kim had done a tremendous job. So thank you all the faculty and all our team which made this possible. Best wishes, good luck, and see you tomorrow morning.
The world is in the midst of a pandemic, and we are on the front lines. Yet cardiovascular disease is still the #1 killer worldwide and can't be ignored. Welcome to Top 10 Topics in Clinical Cardiology 2020. While COVID-19 has challenged us to take our conference online, course directors Dr. Samin Sharma, Dr. Jagat Narula, and Dr. Annapurna Kinney have created a packed and compelling program. Over the next 2 days, you will be exposed to new and emerging approaches in the diagnosis, management, and treatment of heart disease, including COVID-19, opinions of clinical and academic experts, and ways to improve overall care and prognosis. Following our 2 days together, attendees will comprehend the COVID-19 disease process and outcomes, learn to assess CAD risk factors and imaging, acknowledge recent transcatheter valve therapies, recognize the issues pertaining to antithrombotics post-DES, incorporate the latest advances within interventional cardiology. Attendees who are present for both days will receive CME credit. In addition, the full program will be accessible online post-conference on our website, www.ccclivecases.org, and YouTube channel CCC Live Cases. Thank you for joining us. There is nothing quite like the study of cardiovascular disease to remind us to strive towards an active, healthy lifestyle. And remember, wear a mask, wash your hands, practice social distancing, stay safe, and enjoy the conference.